I audible? Oh, oh, oh. Yes. So, good morning, everyone. A very warm welcome to all of you. It's a pleasure to have such a diverse group of researchers, students, and professionals here today for the scientific session at IMA National Sports Conference 2024. This conference brings together a vibrant community dedicated to advancing the field of sports medicine. Today, we have exciting opportunity to witness some of the latest research and innovative ideas that are shaping the future of this field. The scientific presentations are a core part of this conference, offering a platform for both seasoned experts and emerging voices to share their findings, exchange insights, and inspire one another. This session has been organized in collaboration with MGM Institute of Physiotherapy and MGM School of Physiotherapy, CHHATRAPATI SAMBHAJINAGAR, and we are grateful for this partnership in making this session possible together, and we aim to create a space for learning and growth. We are grateful to have with us two esteemed judges, Dr. Vaibhav Kapre, Professor and Head of the Department Cardiorespiratory, MGM Institute of Physiotherapy, Dr. Sabi Khan, Associate Professor, Cardio Department, MGM School of Physiotherapy. Their expertise and guidance will undoubtedly enrich this session and inspire a meaningful discussion, and it will help us to evaluate the presentation. So without further delay, let's begin the session. Now I will invite our first presenter, PA1.
पीपीटी कोणती आहे ओपन केलेली आहे का एक मिनिट हिला क्लोज नव्हतं ये नहीं है
वहाँ पे नहीं है Good morning, everyone. So my topic is impact of Russian current combined with closed and open kinetic chain strengthening exercises on ACL revision reconstruction using allograft, a case report. So in introduction, primary ACL restoration has been found to be a successful intervention with majority of patients experiencing full recovery and good to exceptional clinical results in post-operative evaluations. Professional footballers can rejoin their sport following the reconstructive surgery. Only 67% of them were capable of competing at the highest level 3 years following the operation. Additionally, contralateral ACL tears are infrequently found in the literature. It is to be noted that the first 2 years after an ACL reconstruction are crucial, as ipsilateral graft failure is most likely to happen during this period. The prevalence of the third ACL injury in the general population ranges from 4 to 13%. According to the reports, there are 36.9 to 60.9 ACL ruptures per million person years, 10 to 20% of which are repeat rupture. As long as the tissue is not radioactively treated or is only minimally treated, a safe and more reliable choice for revision ACL restoration is the use of this allograft tendons, which has a comparable failure rate to autografts and no increased risk of infection. So here I present a case of male recreational footballer, aged 23 years old, came to sports OPD for the post-surgical rehabilitation of left ACL reconstruction. In the past, athlete already endured injuries to ACL twice on the left side, which is the ipsilateral side, and once contralaterally as well. The first and foremost ACL tear took place when the athlete was 18 years old, and he underwent ACL reconstruction with lateral meniscus repair, wherein a same-side autograft from hamstring was taken. The player returned to sports after 6 months. A year later, this was followed by another injury to ACL ligament on the right side. The graft used was similar to the previous surgery, and another 6 months were required by the athlete to return to the sports. Third episode of injury occurred to the ACL ligament on the left side and happened when he was 21 years old. An arthroscopic ACL revision was performed using the tibialis posterior allograft plus notchplasty plus meniscomy, trimming and balancing plus medial femoral condyle, bone marrow stimulation plus lateral extra-articular tenodesis was done. It was a complex tear as it involved the medial meniscus posterior horn, including the posterior root attachment. Focal chondral defect was seen in the adjacent inferior articular surface of the medial femoral condyle on the posterior aspect. In the posteromedial corner of knee, a ruptured Baker's cyst was seen with fluid tracking inferiorly in the medial aspect of the proximal leg. The craniocaudal dimensions of the Baker's cyst were 4.2 centimeter. Altered morphology and signal of the lateral meniscus is concerning for a re-tear rather than the post-operative change. Large joint effusion is seen with fluid in the patellofemoral recesses. So the surgical history: patient position is supine with leg holder. Notchplasty was done. ACL reconstruction was done with tibialis posterior graft. Lateral extra-articular tenodesis was performed. Complete meniscal loss was observed. Buccal handle tear was spotted. And post-surgery, the surgeon has prescribed non-weight bearing for the first week, then progressing on to the partial weight bearing for the next 1 week, and then further full weight bearing for the next 1 week. So in pre-rehab physical examination, the patient was assessed on 4 parameters, that is pain, range of motion, strength, and muscle girth. So in pain, NPRS scale was used. The rating was 5 out of 10. In range of motion, the difference in knee flexion, the difference in right and left is 95. In knee extension, there is no difference. In strength, for knee flexors, the difference is 10, and in knee extensors, the difference is 9.5. In muscle girth, above knee 3 inches, the difference is 4. Above knee 6 inches, the difference is 4. Above knee 9 inches, the difference is 2. And below knee 6 inches, the difference is 4. So moving on to the protocol. The protocol for week 4 to 8, we have focused on we have given electrotherapy and thermotherapy. In that, we have given Russian currents along with icing. Then we have given manual therapy, exercise therapy, and aerobic training. For week 9 to 12, the areas focused were strengthening. In that, closed kinetic chain exercises were given, then balance and aerobic training. For week 13 to 16, strengthening, balance, proprioceptive training, and aerobic training was given to the patient. In week 17 to 20, strengthening exercises, in this open kinetic chain exercises were given, then balance, proprioception training, aerobic exercises, then agility and plyometrics was given. For week 21 to 24, areas focused were strengthening, balance, aerobic exercises, agility, and plyometrics. So this is the post-rehab physical examination. There is a significant change in the pain. That is, previous it was 5, now it is 0. Then range of motion, there is no difference. In strength, in knee extensors, 0.5 difference is seen. In muscle girth, the right and left muscle girth is same. So results are here. So in pain, there is a significant difference. That is, pain has significantly decreased from 5 to 0. In range of motion, in the left side, the surgery was performed. So range of motion has increased from 30 to 125 degrees. In muscle girth, the girth has, this is the muscle girth of left leg. That is the pre-muscle girth and post-muscle girth. It has it has been same in the later weeks after the protocol was given, and this is the muscle strength result. These are the images while testing. The results of this study depicted that Russian current combined with closed and open kinetic chain strengthening exercises with progressive resistant exercises of lower limb and core muscles, endurance training of muscle, balance, proprioception, agility and plyometric training was beneficial for improving knee flexion range, the size of thigh and leg muscles, and strength of quadriceps and hamstring muscles, and overall functional capacity of the patient was improved. According to Ukar Mehmet Ali et al., they conducted and concluded that CKC exercises are superior to OKC exercises for mobilization following ACL surgery, allowing for a speedier return to everyday activities and sports. As reported by Buckthorpe et al. In 2019, the quadricep muscle force and PFJ stress are seen to be at its highest point during OKC movements like knee extensions. On the other hand, the quadricep muscle forces and PFG stress are highest during CKC activities like lunges and leg presses close to full flexion. This is proposed mechanism of effectiveness of CKC over OKC training. Amar Elmaz and Edbel Azim and colleagues concluded in their studies that the application of Russian current stimulation in addition to traditional physical therapy increased the quadricep muscle peak torsion. Furthermore, Cinder Mackler et al. Examined the effects of electrical stimulation and voluntary exercises on muscular strength following ACL replacement. Exercise and stimulation groups engaged in quadriceps and hamstring co-contraction with a 15-second hold and then a 15-second rest. The Russian current stimulation group's finding in terms of increased muscular strength were noticeably superior to those of the exercise group. ACL damage and reconstructive surgery negatively impacts balance and neuromuscular control processes. So we restored with that. With balance and proprioception training, further improvement was achieved by agility and plyometric training. So we conclude that application of Russian currents is effective for pain reduction and helped in strengthening of muscles. Initially, we have started with closed kinetic chain exercises and then open kinetic chain exercises. In further progression, vigorous strengthening and endurance training of lower limb and core muscles, balance and proprioception training with agility and plyometric training provides a patient very good recovery and improvement in overall functional capacity of the patient after 6 months of rehabilitation. This all are the references. Thank you.
You have mentioned that the patient has the Baker cyst.
Yes.
What was the physiotherapy treatment you have given? Because you have not mentioned in your case. Any special, Baker cyst was there, no?
Yes.
So what was the treatment given? Because all the other things you have covered.
Yes. Sir, it was mainly so Baker cyst is a fluid or a lump behind the knee. Then strengthening exercises were given. Mainly we have focused on pain reduction. That is, we have done that with Russian currents. And balance and agility we have targeted. And strengthening we have targeted.
So mainly you targeted the Russian current.
Yes.
But what type of study it is?
It is a case report.
Case report. Title, can you show?
Impact of Russian currents along with closed and open kinetic chain exercises using allograft.
But as a research design, only one sample, will it be able to define is it effective?
Sir, actually it was a unique
What
case.
will be your future scope? Just last question.
Future scope. Sir, actually it was a unique case as a patient had third time reconstruction surgery. First time it was on left side, that is autograft was used from tibia, was used, and second time the patient had contralateral injury on the right side. In that also autograft was used, and then again patient had ACL injury on the left side, and then allograft was used from tibialis posterior muscle. So this protocol is unique. this protocol is unique, so we can use this protocol more in ACL reconstruction surgeries. So Russian currents will be combined with strengthening exercises, so this will be useful. Thank you.
Next, we'll have a poster presentation, PO1.
नहीं पोस्टर है एक्चुअली कबड्डी वाला ये नहीं है वहाँ पे दिख नहीं रहा है Good morning all. So the title of my today's poster is Immediate Effect of Lumbar Mobilization versus Neurodynamic Sliding versus Muscle Energy Technique on Hamstring Tightness in Kabaddi Players, a randomized clinical trial. So the background is Kabaddi is a widely played team sport in India. The game's high intensity actions such as running, jumping, and kicking frequently cause injuries with hamstring tightness being a common issue. This study evaluates three techniques: lumbar mobilization, neurodynamic mobilization, and muscle energy technique for their immediate effect in elevating hamstring tightness in kabaddi players. So the objectives of this study is to find out the immediate effect of lumbar mobilization on hamstring tightness, to find out the immediate effect of neurodynamic sliding on hamstring tightness, and to find out the immediate effect of muscle energy technique on hamstring tightness. To compare the immediate effect of lumbar mobilization, neurodynamic sliding, and muscle energy technique on hamstring tightness. So methodology: study type is experimental study. Study design is randomized clinical trial. Sample size is 63. 63 kabaddi players. Sample method was simple random sampling, and the study setting is Kabaddi Academies in CHHATRAPATI Sambhajinagar. So the inclusion criteria of my study is age is 18 to 30 years. Second is minimum 20-degree restriction in active knee extension test unilaterally. Third is participants playing kabaddi at least 3 times a week, and players who are excluded are current symptomatic low back pain and neurological symptoms, history of spinal surgery, and any contraindication to spinal mobilization. So results are described in two types: within group analysis and between group analysis. In within group analysis, all three techniques are demonstrated statistically significant improvement, which is in all three techniques. The p-value is less than 0.05, and in between group analysis there was no significant difference noted among three groups, because p-value is greater than 0.5. So all three techniques are in between group. All three techniques are not statistically in which was not significant difference noted among the three groups. So interventions, they give three interventions in which they give the lumbar mobilization, neurodynamic sliding, and muscle energy technique. In lumbar mobilization, they unilaterally posterior anterior L3, L4 and L5 zygophyseal joint, they give lumbar mobilization, and in neurodynamic sliding they give the sciatic nerve mobilization, and in muscle energy technique they give post isometric relaxation.
So the picture is showing that the neurodynamic sliding technique. Conclusion of my study is in conclusion, all the three techniques were significantly effective in decreasing hamstring tightness. None of the technique was superior to the others, making them equally viable for clinical use in kabaddi players. So these are all are the references, first and two.
Have you have used two groups, no?
Three groups.
Three groups.
Lumbar mobilization.
But you have not mentioned here actually. Poster, you should mention what protocol you have given to
Yes,
each
sir,
of the
but
groups.
intervention I have explained that lumbar mobilization, neurodynamic sliding, and muscle energy technique.
All three.
Three groups, yes. And all three are giving same result. All three are matlab, giving us means useful in reducing hamstring tightness.
Use
all
the
three
mic.
techniques.
Use the mic. Mic.
All three techniques were significantly effective in decreasing hamstring tightness.
Okay.
Equally.
So no control group was there.
No, sir.
So RCT, you should have used some control group, no? So that you can compare whether it is all three maybe. So that is one of the flaws. And how come can you explain how come the lumbar mobilization affecting the length of the hamstring?
No, sir. It is a treatment which is they give the unilaterally on the posterior anterior side of zygophysial joint at L4 L5 with the with giving pressure with pisiform and hook of hamate on the dominant side unilaterally. It is the treatment
Given, but
yes.
have you given in that group stretching to that hamstring in that group or just
No, sir.
mobilization?
Yes, mobilization.
How it can affect the lengthening of the hamstring?
What are the limitations for this study?
Sir, thank you.
Next will be PA2.
So good morning everyone. So I'm here for the paper presentation on the topic comparison of lumbosacral alignment among obese and overweight students. So here I start. Overweight is defined by BMI of 25 or higher, or obesity indicated by BMI exceeding 30. So what is BMI? BMI is body mass index, in which we calculate there are the ratio by which BMI is calculated. So in this, the obesity is more than 30 and overweight is more than 25. Even we have the criteria for obese in 3 grades. So more than 30 to 34.59 is grade 1, class 1 obesity. Then class 2 is more than 35 to 39, and then more than 39 is class 3 obesity. So there is higher prevalence of overweight and obesity among females compared to males. The majority of research findings establish a strong relationship between obesity and risk of developing lower back pain and arthralgia. Spinal kinematics are essential for performing daily and locomotive activities. The lumbosacral joint is formed by fifth lumbar vertebra and the first sacral segment, which forms an angle with the horizontal known as lumbosacral angle. So as there is an anterior tilting of the sacrum increases, this angle increasing anterior lumbar convexity while standing, which is crucial for proper spinal function. Obese individual may displace the sacrum base anteriorly, increasing the lumbar sacral angle. Lumbar lordosis refers to curvature adopted by the lumbar spine to counterbalance the sacral inclination, restoring an upright spinal posture and preventing forward tilting. Increased lordosis is major cause of pain, radiculopathy and facet joint pain, while decreased lordosis angle contributes to lower back pain. Sacral angle is potential risk factor for lumbar disc degeneration. Sacral inclination angle is angle between a vertical plane and a tangential line to the posterior border of S1 vertebra. Sacral inclination is categorized as dorsal inclination. This is the angle between a line parallel to back of the proximal sacrum and the horizontal plane. Or cranial inclination, the angle between a line parallel to upper end plane of sacrum and a horizontal plane. Overweight and obese individuals tends to exhibit higher sacral inclination angle. This study compares various lumbosacral alignment parameters, including lumbosacral angle, sacral inclination angle, and lumbar lordotic angle among overweight and obese individuals. So, the method, the study was conducted in MGM School of Physiotherapy, and sample size was 70 students among the age of 18 to 25 years. So, as the method, screening of participants based on inclusion and exclusion criteria. As the inclusion criteria was 18 to 25 years of age people, consent form was taken and BMI was calculated among the overweight and obese individual. Grouping as per the BMI, overweight and obese, measurement of lumbosacral alignment with the spinal mouse, comparison and the result. So inclusion criteria, individual 18 to 25 years, consent to participation, possessing a body mass index of 25 and above. Exclusion criteria, any neurological or metabolic disorder, spinal injuries, deformities, prior history of spinal surgery or lower limb deformities. So as a result, as I said, that there were 70 participants were included, comprising 35 overweight and 35 obese individuals. The aim was to compare lumbosacral alignment between the overweight and obese adults. So here are the results. As there is mean and standard deviation were taken. As the bluish is for overweight and orange reddish is for obese individuals. So among the lumbosacral alignment, overweight mean 37.40 and standard deviation was 4.16. The p-value is 0.155. So the p-value for LSA, that is lumbosacral alignment, was 0.155, indicating no significant difference between the two groups. Same for the lumbar lordosis angle, p-value is 0.001, which denotes significant difference between both the groups, that is overweight and obese. Same for the sacral inclination angle, the p-value is 0.001, which denotes a significant difference between both the groups. So as here the p-value less than 0.5 was considered as a significant. So the conclusion, according to study finding, significant difference were observed between overweight and the obese individual in terms of lumbar lordosis angle and sacral inclination angle. However, the difference in lumbosacral angle between the two groups were found to be non-significant. So implication, understanding the relationship between the lumbosacral alignment and the BMI can have important clinical implication for physiotherapists and healthcare professionals. It provides them with the knowledge that can be used to develop more targeted intervention and treatment plans for individuals who are overweight or obese, particularly in managing and musculoskeletal issues related to spine. So discussion, Primary objective of the study was to assess potential difference in lumbosacral alignment between the obese and overweight individual. Findings indicate that subjects with obesity exhibit higher lumbosacral angle compared to those with the overweight category. According to our study, a significant difference exists in sacral inclination angle between overweight and obese individual. Elevated lumbosacral parameters were observed in obese individual compared to overweight individual. However, no significant difference was detected between overweight and obese individual in terms of lumbosacral angle, while significant disparities were noted in lumbar lordosis angle and sacral inclination angle values. So these all are the references.
Study design.
Cross-sectional study, which is
Can you
observational.
Objectives. Can you show?
Yes, sir.
Objectives. Can you show again?
Yes.
Objective. Just go back. No, you have not mentioned some titles. You have not mentioned properly, and discussion also you have after conclusion. It should be before conclusion discussion always.
Yes, sir.
Okay, that part you have to take care. Limitation and future scope. Limitation, can you?
There was not that limitation, but future scope, we can modify the study as we can do it between malnutri and mesomorph and endomorph individuals for comparison.
How did you calculate the sample size?
Calculate by mean and standard deviation. Thank you.
Next, we have a PO3 for the poster presentation. Sorry, we'll have next poster presentation, that is PO2.
Good morning all present here. So my today's topic is correlation between the strength of scapular stabilizer with forearm pronator and supinator muscles in elite tennis player and observational study. So first with introduction. So tennis is a high intensity sports that includes the two squads of two players in each game or the one player on each side. It requires the strong proximal and the distal muscle strength. To play tennis strokes, the functioning of kinetic chain should be proper as the energy needed for power stroke is produced from bigger to smaller muscles. So there is a great requirement of the good agility, good balance, strengthening, and the aerobic and the anaerobic endurance should be there. So changes in the working of kinetic chain can lead to complications and further leading to injuries. Bigger muscle fuel power stroke supported by scapular stabilizers, so that the scapular stabilizer plays the key role in transferring the force or the power to the smaller group of muscle. So forearm pronation adds wrist speed for impactful strokes. Finding the correlation between the scapular stabilizers and forearm pronators and supinator muscles will help to improve an athlete's performance and reduces the risk of injury. The aim of the study is to find if there is any correlation between strength of scapular stabilizers with forearm pronator and supinator muscles in elite tennis players. In the objectives are to calculate the strength of scapular stabilizer muscles like upper trapezius, middle trapezius, lower trapezius, and serratus anterior, and to calculate the strength of pronator and supinator muscles of forearm. And the third is to find the relation between both the values. The third methodology, the study setting is tennis club situated in Aurangabad, Maharashtra. Study population elite tennis players. Sampling method used were convenient sampling method. Study design is observational study, cross-sectional study, and the sample size were 39 males, right-handed players were included, and the study duration 2 years. In the inclusion criteria, male tennis players were included, age between 18 to 30 years, players practicing tennis from more than 3 years, players practicing at least 3 times a week. In the exclusion criteria, players having any upper limb injuries, neck pain, or restrictions to their movement or pain were excluded. In the methodology flowgram, we can see that the total tennis player was screened were 15 players, but the 11 players were excluded from the study because they were not meeting the exclusion criteria. So total players enrolled were 39 players. The procedure was explained and asked to sign the informed consent to the elite tennis players, and the general characteristics including name, age, gender, and dominance were taken from them. So their first check for this strengthening, scapular muscle strengthening, was measured using the handheld push-pull dynamometer, which we can see into the picture. The first picture shows the baseline hydraulic wrist dynamometer to check the supinator and pronator muscle strength. And then in the second image, we can see that there is a handheld push-pull dynamometer which is used to assess the strength of the scapular stabilizer muscles. After that, in the result part, we can see that there is two graphs were given. First is association between supinators and scapular muscles, and the second is association between pronator and scapular muscles. So there is a correlation was present between the scapular and forearm pronator and supinator muscle. We found low negative relation and low positive relation. In low negative relation, that means there is a low negative means there is a relation so that the muscle activity reduces, so that leads to the reducing the muscle activity of another group of muscle. We found low negative relation between pronator and serratus anterior and middle trapezius. That means the decreased activity of pronator muscle leads to the decreased activity of the serratus anterior and middle trapezius muscle, while on the other hand the pronator upper and lower trapezius muscle indicated a minor positive connection. That means there is a slight increase in the muscle activity of pronator leads to the increase in muscle activity of the upper and lower trapezius muscle. On the other hand, the supinator muscle displayed a low positive relationship with the serratus anterior and upper trapezius. That means there is a increase in the muscle activity of supinator muscle leads to the increase in activity of serratus anterior and the upper trapezius muscle, while on the other hand the supinator showed a very low negative relationship with the middle trapezius and lower trapezius. That means the decrease in the supinator muscle activity leads to decrease in middle trapezius and lower trapezius activity. So they concluded there is a correlation was present between the scapular and the forearm pronator and supinator muscle, and the clinical implication of this study is to finding the correlation will help to improve the athlete's exercise protocol and to reduces the risk of injury. And the future and the limitation of this study is that they can take the larger sample size, they can include the females also. Thank you. And the references are given.
Can you explain the need of study?
The need of study to reduces the risk of injury in athletes, and they can maintain the kinetic chain balances in athletes also.
So is it very frequent that these type of injuries are very commonly seen with the tennis players?
In lawn tennis player, there is chances of getting the shoulder injury, so they can balance the dynamic balance between the scapular stabilizers and the forearm muscles to prevent the shoulder injuries.
What is the conflict of interest in your study?
In conflict of interest, they can include the larger sample size.
What is your conflict of interest in your study?
They can add the different age groups. They only included.
That is the limitations. What is the conflict of interest?
That is limitation of this study, but in the future recommendation.
Why do we have an inclusion criteria in the research? And why it is
to-
always a very specific inclusion criteria in any research? Then how this sample is calculated?
Sample is calculated using the statistical SPSS version 29, and the Pearson coefficient correlation was used to measure the correlation between these two data.
Next we'll have a PA3.
Good morning, all. The title of the paper is Effectiveness of Hip and Core Muscle Training versus Gait Retraining on Running Performance, VO2 Max, and in long distance overstriding runners, a multi-arm randomized control trial. This is the overview. Introduction. Running is a fundamental form of human movement that is essential in various sports. The performance of long distance runners is influenced by multiple factors, including biomechanics, muscle strength, running economy. Overstriding, one of the biomechanical factors, occurs when the foot lands far ahead of the body's center of mass at loading response, approximately 1/3 of the length of the foot. So this is the overstriding. Overstriding measured at loading response. In picture A, a runner demonstrating normal stride, that is, the foot is landing below the center of mass. Then in picture B, we can see a runner is demonstrating an overstride characterized by a vertical line through the lateral malleolus falling anterior to the runner's pelvis. So what are the consequences of overstriding? It increases the braking forces, which reduces the running efficiency, requires more energy and propulsive force, negatively affecting running economy. It contributes to running related injuries due to higher joint loading and ground reaction forces. So what is the performance impact? Overstriding is common among untrained runners and reduces running efficiency compared to skilled runners who tend to avoid it. Now, what are the solutions for overstriding? Reducing overstriding lowers braking forces, improves energy efficiency, and maximizes elastic recoil. The strategies include shortening step length, increasing cadence, improving hip extension, and trunk lean. The intervention that target at this biomechanical solution are gait retraining, which focuses on increasing step frequency, decreasing step length to reduce overstriding; hip and core muscle strengthening, which supports proper posture, pelvic alignment, reducing reliance on knee extensors and limiting overstriding. So the aim of the study was to compare the effectiveness of hip and core muscle training and gait retraining on running performance, VO2 max, in long distance overstriding runners. Methodology: the study design was a superiority parallel multi-arm randomized control trial. Study setting: local training centers, Garkheda, Garware, and MGM Stadium. The study duration was for 12 months, that is from July 23 to June 24. Materials used were Garmin watch, stopwatch, Kinovia software, metronome device, smartphone camera. Sampling method was convenience sampling. Method of randomization was block randomization. Blinding was the outcome assessors were blinded. Sample size was 78 participants. This is the study flowchart. 156 participants were assessed for eligibility, out of which 78 were randomized into 3 groups. 78 participants were excluded because they did not meet the inclusion criteria. Inclusion criteria was the runner has to run more than 15 kilometers in a week, and their age should be between 18 to 40 years, and the exclusion criteria was any musculoskeletal or neurological injury in the past 3 months. Then after assessing for eligibility, pre-testing of the outcome was done. Running performance was measured by 2.4 kilometer time trial. Then running economy was measured on the Garmin watch for the VO2 max, and overstriding was measured on the Kinovia software. A video was taken of the runner in sagittal plane, and then it was analyzed in the Kinovia software. Then the runner was randomized into either of the 3 groups, in the hip and core muscle training group, gait retraining group, and the control group. Out of all the runners, only 2 lost follow-ups in the gait retraining group. Rest of the runners, that is 76, were analyzed for the result. The intervention control group were given, performed their warm-up as usual, and a flyer on overstriding was given to them. Hip and core muscle training group, this intervention group was exclusively performing the hip and core muscle exercises under supervision. The participant was instructed to perform all 6 selected exercises 3 times per week for 6 weeks, which were progressed every 2 weeks. And in the gait retraining group, after randomization, individuals in their group downloaded the software in their mobile phone named Metronome Beats. Each subject's preferred cadence was determined while performing the baseline assessment of VO2 max on Garmin watch. This group performed interval training using Metronome Beats, a 5-minute bout of running at 10% increase in cadence, followed by 2 minutes of rest for 3 intervals 3 times in a week, which was increased by 1 interval every week till 6th week. So this is the flyer which was given to the control group. These are the hip and core muscle exercises. The first one is Russian twist, second one is bird dog, third one is single leg bridge, and then here the fourth one is single leg deadlift. Then the Copenhagen plank position, it is a modified version, and then the prone plank. For the gait retraining group, on the Metronome Beat app, the cadence was determined and it was given to the runner, and in the second picture you can see the participant is synchronizing his stride to the Metronome Beats during gait retraining session. So in the result, there was significant improvement within the groups, but between groups there was no significant difference in the running performance and the VO2 max in all the 3 groups. However, in the overstriding outcome, the gait retraining group proved to be significantly better than the other 2 groups. Here in the box plot we can see the middle graph is the distance of overstriding was reduced more in the gait retraining group. Discussion. The current study aimed to establish how hip and core muscle training and gait retraining compare in terms of their effect on running performance, VO2 max, and overstriding distance. The observation demonstrated that hip and core muscle training and gait retraining intervention induce significant enhancement of running performance parameters with minor shift in group differences in the manifestation of this improvement. The lack of significant differences in post-intervention of VO2 max between the group suggests that both interventions have similar impacts on the aerobic capacity. In conclusion, the study demonstrated that gait retraining can significantly enhance running performance, VO2 max, while reducing overstriding distance in runners better than the hip and core muscle training group. This finding emphasized on the importance of biomechanical refinement into regular training regimes for runners. By adopting this strategy, runners can achieve more efficient and safer running mechanics, ultimately leading to better performance outcome and lower injury rates. These are the references. Thank you.
Can you explain how you have assessed the VO2 max?
Sir, VO2 max was assessed on the Garmin watch. The runner was asked to wear that watch and he was asked to run for 15 minutes, and the data on the Garmin watch uses first beat technology in which they combine the speed and heart rate, and then with the data they evaluate the VO2 max.
But validity, reliability?
So for the validity, a white paper was published by the first beat technology. The mean absolute percentage error was found to be 5%. And another article was published for the validation in 2023 in Technologies journal. So in that they found the correlation with the gas analysis, which is the direct method, of 0.8 of correlation was found.
So funding
For no sir, no funding. No
So,
funding.
okay. So you have purchased that.
Yes sir, I had that was sir. So
Okay. And one more thing, you have used marathon runner or sprint?
long distance sir. So in long distance, from 1.5 kilometer who runs until 42 kilometers, all the runners are included. All the recreational and sub-elite runners are included.
What is the sensitivity and specificity of that watch?
Sir, till date, no study has been done on the sensitivity and the specificity, but the correlation studies and the technology has been validated by the issuer.
I'm just giving an example. For example, we are using MRI, CT scan, and
Yes.
X-ray.
Yes, sir. Yes, sir.
So specificity and sensitivity, if you compare three of these machines, the specificity, sensitivity is in MRI is more than this. So the practical approach to use the best thing is MRI. Just example.
Yes, yes.
So is it feasible for you for using a machine which has not been sensitized and
But,
specified?
So to that, the gas analysis which is used for VO2 max, which is the gold standard, it doesn't have a real life application. So when a runner is running outside, he cannot wear a mask for the gas analysis, and that cannot be accurately measured. So comparing to that, using a watch which is more handy, the analysis can be done outside also, and it is less expensive.
What is your conflict of interest?
So, sir, the conflict of interest of my study was I had sub-elite runners, which are more experienced runners, could have been included in the study.
What do you mean by conflict of interest?
So the conflict I have with this study, the conflict of.
Okay.
Thank you, sir.
Next, we'll have a poster presentation, PO3. Good morning, everyone. I am here to present a poster. The topic is correlation between Q angle and foot muscle strength along with foot angles in professional Bharatanatyam dancers. This is an observational study. Bharatanatyam is a South Indian classical dance. It demands intense repetitive movements which challenges the dancer's flexibility, strength and stamina. This also increases the risk of repetitive strain injuries, which also has long-lasting effects. So common techniques are Aramandi, which is half squat position, and one more is tapping technique, which is commonly used, and the repetition is a lot. So the key factors include quadricep angle, which is crucial for knee alignment, and toe strength, which is measured with a dynamometer. Misalignments in the rear foot and forefoot, they can cause compensatory actions, which increases the injury risk. The objectives, there are two objectives. Primary objective was to find the correlation of the Q angle with foot angles in professional Bharatanatyam dancers. Secondary objective was to find the correlation of Q angle with foot muscle strength in professional Bharatanatyam dancers. Study setting was the Bharatanatyam Academy in CHHATRAPATI SAMBHAJINAGAR. Study population was professional Bharatanatyam dancers. Study design was a cross-sectional observational study, and the duration of the study was 2 years. Sample size was 40 female Bharatanatyam dancers. Sampling size was convenient sampling. Study materials that were used were standard goniometer to measure the foot angles and Q angle, toe grip dynamometer
to measure the strength of the muscles, foot muscles, and handheld push-pull dynamometer to measure the strength of the ankle muscles, and a marker and a ruler. Criteria of inclusion was age 18 to 30. Only female Bharatanatyam professional dancers were included with an active dancing experience of 2 years. BMI was 18.5 to 24.9, which is normal BMI. Exclusion criteria: any history of any surgery of lower limb or any other orthopedic condition, any musculoskeletal condition, neurological deficit, or congenital abnormality of leg or foot which can affect the functionality of the lower limbs. Dancers who are playing professional outdoor sports like football, athletics, basketball, swimming were also excluded from the study. The results show that there's a positive relationship between Q angle and foot angle on the right side. It was very high to strong positive relationship, and on the left side it was high to very high positive relationship, and on the between the foot muscle strength on the right side it was very high to strong positive relationship, and on the left it was high to very high positive relationship. So the conclusion is there's significant relationship of Q angle and foot muscle strength along with foot angles in professional Bharatanatyam dancers. These are the references. Thank you.
In inclusion criteria, you have used, I think, 2 years of active dancing experience.
Yes,
Why
sir.
not like earlier 3 months or 6 months?
Sir, because
Because injuries
at
are
that
seen-
point they'll know major techniques of Bharatanatyam by 2 years. That's why only they were included, and because these is in professional dancers it was taken, so 2 years was taken, sir.
Okay. Any need of the study?
The need of the study, because of repetitive tapping movements, the arch of the medial longitudinal arch of the foot, it reduces, it becomes flat foot. So because of that, the overuse injuries are very common. So to reduce that, it was done, to see, observe and see.
You have taken the reference बताओ एक मिनट. हाँ. The first reference is from 1998. That means 26 years ago reference you have taken.
Yes.
And the second reference is 2010. 14 साल पहले का reference है. How did you justify this?
Sir, Bharatanatyam was not included in sports. So because of that,
There are n number of studies in Bharatanatyam. Okay, my second question is, do you think there is any relationship between Q angle and the height of the participant?
I'm not sure, sir. Thank you.
Next, we'll have a 10 minutes break. So after that, we'll again join us.
Mike.
है ना. We'll start with the session PA4.
Good morning, everyone. So the topic is comparison of lower limb muscle activity between lumbopelvic hip complex and lower leg dysfunction during overhead squat in badminton players, a cross-sectional study. Introduction. Engagement in sports like badminton improves quality of life by promoting fitness and fostering social bond. Badminton is one of the most popular game in India, demands a high level of endurance, agility and precision, primarily through overhead strokes. So when the players go for overhead stroke, usually they land in single leg landing. So during single leg landing, the knee valgus increases, which increases the chances of significant risk of lower limb extremity injuries such as ACL tears and patellofemoral pain syndrome, often due to excessive medial knee displacement, which is commonly known as dynamic knee valgus. Dynamic knee valgus occurs when the patella shifts medially towards the great toe, driven by femoral adduction, internal rotation at the hip, and tibial adduction and external rotation in the lower leg. Weakness in hip and ankle musculature may further contribute to this instability. The overhead squat is an accessible screening tool for assessing movement quality in athletes and daily activity, evaluating multiple joints and muscle groups. It requires no special equipment, making it suitable for various populations. Clinicians use heel lift to differentiate between MKD, it is arising due to lumbopelvic hip dysfunction or lower leg dysfunction. During overhead squat, if an individual knee still moves inward after lifting the heel, the area to be addressed is lumbopelvic hip dysfunction. If the compensation is corrected, then we can say MKD is due to ankle complex movement. Surface EMG is a practical and cost-effective tool for measuring muscle activity during dynamic exercises, widely used in sports and rehabilitation research. It assesses the electrophysiological processes of muscle contraction and force generation. So the aim of this study was to examine the muscle activity during overhead squat among badminton players. We hypothesized that there is difference in lower limb muscle activity between lumbopelvic hip complex and lower leg dysfunction during overhead squat in badminton players with medial knee displacement. Material and methodology. Study design is a cross-sectional study. Study setting, Institute of Physiotherapy Sports OPD. Study duration 1 year. Target population, recreational badminton players. Sampling method was convenient sampling. Blinding, there was no blinding. Sample size is 70. Sample size calculation, though this formula was used, and minimum sample size was 70. Inclusion criteria, badminton players of both gender, age between 18 to 30 years. Recreationally active badminton players, which is defined as active defined as doing physical activities including running a minimum of 3 times a week for at least 30 minutes. Exclusion criteria, no history of injury to the hip, knee, hip, back or ankle in 3 months prior to the testing. No history of lower extremity surgery in the past 1 year. No complaint of low back, knee and ankle pain. Participants having frontal plane projection angle less than 180 degree will be excluded. So the flowchart for the study was, first we will assess the overhead squat, and during the overhead squat one photo will be taken, and on that that photo we will put in the Kinovia software, and from that we will take the frontal plane projection angle, and according to the frontal plane projection angle we will divide the participants into 2 groups, experimental group and control group. In experimental group, then again after overhead squat we will perform squat with modification, and again the participants will be divided into MKD due to lumbopelvic hip complex and MKD due to lower leg dysfunction. After that, the electrode placement, the surface electrode will be placed for gluteus maximus, vastus lateralis and lateral gastrocnemius, and muscle activity of gluteus maximus, vastus lateralis and lateral gastrocnemius during overhead activities checked. So this is the EMG analysis which is done during overhead squat for vastus lateralis muscle, and this is the frontal plane projection angle for lower leg dysfunction group. So the results of the study was, when we one way ANOVA was used to compare between the groups. So we found that lateral gastrocnemius activity was statistically significant between all the groups, and to know between which group it was more significant, post hoc test was done, and it was found that group 1 versus group 2, that is lumbopelvic hip complex group and control group, lumbopelvic hip complex and lower leg dysfunction group showed statistically significant difference. So discussion, our research key finding indicates that there was no statistically significant difference in percent MVIC, that is muscle activity of gluteus maximus and vastus lateralis across all the 3 groups, but there was statistical significant difference for lateral gastrocnemius with lumbopelvic hip complex dysfunction and lower leg dysfunction show statistically significant difference. The difference was found between lumbopelvic hip complex and lower leg dysfunction and between lumbopelvic hip complex and control group. However, no difference was found for the control and lower leg dysfunction group. Our result highlights that altered lateral gastrocnemius activity, particularly in context of lumbopelvic hip complex dysfunction and lower leg dysfunction, could play a more significant role in the biomechanical dysfunction associated with the medial knee displacement. The absence of significant difference in gluteus maximus and vastus lateralis activity across the group further indicates that this muscle may not be directly implicated in medial knee displacement as previously thought, though their interrelationship is noteworthy. In the present study, a moderate positive correlation was observed between gluteus maximus and vastus lateralis in the lumbopelvic complex group, suggesting that change in one muscle activity could be associated with change in the other. On the other hand, the lack of significant relationship between gluteus maximus and lateral gastrocnemius in MKD indicates that this muscle may not operate independently, highlighting the complexity of lower limb biomechanics. A study by Lindsay et al. Concluded that MKD might result from altered muscle coordination rather than simple hip muscle weakness, which is consistent with the current study finding that hip muscle activity alone does not account for the presence of MKD in the lumbopelvic hip complex group. This research highlights that the lateral gastrocnemius as a potential target for intervention in individuals with lumbopelvic hip complex dysfunction and MKD, rather than focusing solely on hip or quadriceps strengthening. The findings suggest that the compensatory overactivity in the lateral gastrocnemius may contribute to altered knee mechanics and increase ACL injury risk. So the conclusion of this study is overactive of the lateral gastrocnemius, especially in the context of lumbopelvic hip complex dysfunction, may be a key contributor to medial knee displacement, potentially more than gluteus maximus and vastus lateralis. The observed moderate positive correlation between gluteus maximus and vastus lateralis points to an interdependent coordination pattern that could influence knee stability. Effective rehabilitation and injury prevention strategies for athletes prone to medial knee displacement should prioritize the assessment and correction of the lateral gastrocnemius overactivity, particularly in those with lumbopelvic hip complex dysfunction. Furthermore, it emphasized the importance of holistic approach that considers the interrelationship between hip, knee and ankle muscles in maintaining optimal knee biomechanics. These are the references. Thank you.
After knowing this results, what will be your future scope regarding this study?
So future scope will be, as we found that lateral gastrocnemius activity was more. So we can plan an intervention where we will work to reduce that overactivity, like focusing on that particular muscles.
And EMG, regarding EMG, in each and every individual you have undergone with the EMG activities.
Yes, sir.
So any pattern or images you have not included in your this slides?
So I have not included in this slide.
Okay. So what was the result? Any marking regarding EMG you have observed?
Like where was the electrode placed?
No, the results. What dysfunction you have found?
So that the lateral gastrocnemius activities was more in lumbopelvic hip complex. That was the main finding of the research.
Can you tell what exactly the correlation you are getting after, like, for example, you are saying lumbopelvic hip complex and lower leg dysfunction and the relation of muscles. So you can just explain your result in a way that anyone can understand how this dysfunction and how the muscle activities is being related, and how this result will be clinically significant or clinically useful for any clinicians.
So ma'am, like we have used overhead squat. So we can differentiate if it is because of hip, like the knee valgus is because of hip or ankle, through using heel lift. So for that we use a pad and we ask the patient to squat on that. So if the dysfunction corrects, so we can say that it is because of, if the differentiation gets correct, so we can say it is because of knee. But if it is not get correcting, so we can say it is because of hip. So the main focus will be in that we'll focus on hip, and if it is getting corrected, then we'll focus on ankle. But the results of my study was that in lumbopelvic hip complex, it was more because of lateral gastrocnemius activity. So we can target that specific muscle for reducing in activity. But interrelation was found between gluteus maximus and vastus lateralis. So we can say that it is not the muscle coordination is the problem, not the muscle strength. So we can work on that, more holistic approach on 3 muscles. Thank you.
Now we'll have a poster presentation, PO4.
Good morning, ma'am. Good morning, everyone. So the topic for my poster presentation is a two-dimensional analysis for comparison of biomechanical and gait parameters between male and female young adults with obesity. So the introduction is the accumulation of excess body fat is obesity. A BMI of 30.0 and above is considered as obese. Gait patterns can be altered due to it and causes risk of developing OA and falls. There is significant biomechanical variations in joint angles majorly found in the overweight females. The aim and objective of the poster is to compare gait and biomechanical parameters among obese young adults, males and females. Objective is to measure gait and biomechanical parameters in obese adults, males and females. The instruments used were 2D motion capture camera, measuring tape and Kinovia software. The methodology used was the study type observational study. Study design was non-experimental hypothesis testing design. A sample method, purposive sampling. Sample size was 42, which was divided into 2 groups of 21 each. Study duration was 6 months. Study setting was done in the MGM Physiotherapy Rehabilitation Center. Inclusion criteria was BMI above 30.0 kg per meter square. Age was 18 to 25. And also the individuals willing to participate. Exclusion criteria was individuals without any individuals with any orthopedic, neurological system or systemic conditions, individuals with recent history of trauma or surgery, and individuals with any congenital deformity. So after the study, it was found that there is difference in the gait and lower limb biomechanics, BMI, Q angle, heel strike, hip and knee movements, and pelvic inclination. And the references are given below. Yes, sir. So I have not mentioned the conclusion. The conclusion was the from the sample size of 42, and they were divided into 21. So it was found that around 43% of the participants which were included in the study were having gait and biomechanical changes in their gait and biomechanical changes, and it resulted in the abnormal gait patterns, like the step length and stride length were decreased due to it, and also there were the cadence was less.
Why only 18 to 25 years of age you have chosen?
So right now that is that population, the age group of 18 to 25 population is suffering from the obesity at the highest level in today's problem. And
experimental hypothesis testing design. Spelling गलत है उसका. Experiment.
yes sir.
ठीक है.
Double I.
Next will be PA5.
Good morning, and thank you for the opportunity to present my research. So the title of my research is Comparison between Motor Learning Strategies and Hip Knee Muscle Strengthening on Cutting Movement in Kabaddi Players, Implications for Preventing ACL Injury. This is a pilot RCT. So introduction. An anterior cruciate ligament injury is one of the most serious and disabling injuries an athlete may sustain, with numerous effects on their physical, mental and financial well-being. So we know that with an ACL injury, the normal recovery time it takes to 9 to 12 months. So it places a major fallback on the performance of the athlete and his career. So ACL injuries account for 86.5% of all sports injuries in North Indian epidemiological research, with meniscal injuries coming in second with 78.24%. In 70% of the cases, non-contact ACL mechanism results in ACL injury, whereas direct injury causes only 30%. So because it is non-contact injury 70%, there is a high chance that we can prevent those ACL injuries. So high impact activities like change of directions, which is one of the side cutting movements, are the main causes of non-contact ACL injuries. In India, Kabaddi and football are the two sports that cause majority of ACL injuries in India. The inability to retain and use newly acquired motor skills, such as the careful alignment of hip, knee and ankle that is stressed in inappropriate landing positions, may be one of the major causes. So when teaching athletes safe movement patterns and offering individualized feedback, adding video instructions or feedback to routine training may help target suboptimal long-term results and improve ACL injury prevention strategies. Programs have been demonstrated to be beneficial in minimizing ACL injury without employment of strength training when they're integrated with other techniques. But the role of proper strength training, solely strength training on injury prevention, has not been yet discovered. For assessing the quality of side cutting movement, the Cutting Movement Assessment Score, that is CMAS, is a validated and reliable quantitative screening tool. There are strong relationships between Cutting Movement Assessment Score and peak knee abduction movements. A higher total score is typically a sign of suboptimal technique and increased risk of non-contact ACL injury. So the purpose of this study is to therefore determine the feasibility of motor learning strategies and hip knee muscle strengthening on Cutting Movement Assessment Score and dynamic knee valgus during the single leg squat. Methodology. So before beginning of this study, we had taken ethical clearance from the ethical committee. The study design was a pilot randomized control trial. So the participants were divided into 3 groups. The first group had motor learning intervention. Second group had strength training, which included hip and knee muscles. And third group was the control group. So control group had no intervention because we are not treating any injury. So that's why control group did not have any intervention. Study setting was MGM Sports OPD. Study duration was of 1 year, but the intervention duration was of 6 weeks. Study material needed was 3 smartphones, Kinovia software and 3 tripods with cones. Sample size, as this was a pilot randomized control trial, the sample size was divided into 30 and it was divided into 3 groups of 10, 10, 10. Sampling method used was convenience sampling. Allocation method, it was used by computer generated block randomization technique. Inclusion criteria. So male and female kabaddi players with age groups of 18 to 30 years were included. They need to be practicing 3 times a week with experience of more than 1 year and a high cutting movement assessment score of 7. Exclusion criteria included history of lower limb injury or surgery in the last 6 months, any abnormal potencies to reduce lower limb performance, pain or discomfort while performing movements, and tests included in the study. So results. So this was the demographic data. So as you can see, the demographic data, it is not baseline data. It is not significant for any group. So it is said that all the groups were similar at the baseline. For within group analysis, 3 of the 3 groups, motor learning group has only showed within group differences significant pre and post treatment. For other both groups, strength training and control group, they did not have any significant changes. For between group analysis, we had used one-way ANOVA test to see if there is any significant change. And when there is a significant change, we have used the Tukey's test to find out which group has performed better. So as you can see in all the cases, the 45 degree is the angle at which the side cutting movement was being performed. So in all the cases, motor learning group has, is compared with strength training and control group. So it has performed better in all the groups. Strength training group versus control group, there is no statistically significant because the p-value is more than 0.05. So that's why we can say that strength training did not perform better than control group. So motor learning is a better strategy for preventing ACL injury. So this is the comparison of frontal plane projection angle of the right side pre and post treatment. As you can see, there is no statistical significance in any within group analysis as well as between group analysis. Same for the frontal plane projection angle at the left side. No significant difference in the within group as well as between group analysis. So discussion. The study was conducted to determine the feasibility of the pilot randomized control trial investigating motor learning and hip knee muscle strengthening on cutting movement assessment score. The study also assessed the feasibility of motor learning strategies and strength training on dynamic knee valgus during the single leg squat test. In between group analysis, motor learning group showed a significant difference in all angles compared to strength training group and control group, suggesting it was superior to both treatments. Strength training group did not have any significant difference in any group compared to control. Motor learning is a dynamic and multifaceted process involving profound physiological changes in the brain, nervous system and muscles. Through neural plasticity, proprioceptive feedback, muscle adaptation, and the interplay of different brain regions, motor learning allows the body to perform movements more fluidly, accurately, and automatically. The study was on motor learning was supported by a systematic review conducted by Anne Benjaminis in 2014. The systemic review examines innovative instructional methods used in ACL injury prevention program. A total number of 9 articles were included in this study. The review highlights the evolution from traditional teaching approaches to a more novel methods, including technology, enhanced learning, real-time feedback systems, and gamified or interactive training programs. For the single leg squat test, all groups have shown non-significant changes in the within group analysis as with between group analysis. This was contradictory to the previous research done by Broadswer, examining the impact of 3 standing exercises on dynamic knee valgus and balance with poor knee control among young football players. The study design consisted of a control group that received no intervention compared to the exercise group that performed 3 standing exercises using a parallel group randomized trial. After 6 weeks of this exercise, the study showed that among young football players with weak knee control, there was no statistical difference within dynamic. There was statistically significant variation in dynamic knee valgus and dynamic knee balance values. This variation in results might be due to different muscles chosen by both studies, because they have included tibialis posterior and I have included here gluteus maximus, gluteus medius, and hamstring muscles. So conclusion, the result of the present study concluded that motor learning intervention for kabaddi players with high cutting moment assessment score showed significant improvement. This improvement is better than those achieved by the strength training exercise and control group. It has yielded positive outcome leading to improved lower limb side cutting movement. This approach not only corrects the faulty side cutting movement but also reduces peak abduction movement. The study concludes that motor learning approach is a feasible intervention which can be applied to improve side cutting movements pattern. These are the references. This is the cutting movement assessment score. So it is a 9-point scale in which total score is of 11. So higher the score, more prone is the person to ACL injury. These are the photos of assessment of frontal plane projection angle, hamstring strengthening using dynamo, and the first picture is of assessment of cutting movement assessment score through Kinovia software. Thank you.
Limitation.
Sir, the most probable limitation is that we are doing this study in a controlled environment. So normally when ACL injury occurs, it is going to be on field. So we have to see that if this techniques which they have learned, they are being able to apply that in the real game environment also.
What is the specificity and sensitivity of 2K test?
What, sir?
The specificity and sensitivity of the test 2K test.
Sir, the cutting movement assessment score. Okay, so sir, for that reliability has been calculated. For the inter-rater reliability is 0.75, and for inter-reliability it is 85%. Thank you.
Next will be PA6.
Good morning, everyone. So title for my study is Accelerated ACL Healing with Cross-Bracing Protocol and TECA Therapy, a MRI-based case report. Introduction. An anterior cruciate ligament tear is a prevalent knee injury, particularly among the athletes engaged in sports that involve sudden stop, change in direction, jumping, and landing, such as soccer, basketball player, and football. The ACL is a cruciate ligament that connects the femur to the tibia, providing stability to the knee joint. ACL is one of the most important ligaments which provide the 90% of the stability during the anterior tibial translation. These ligament injuries are significant global health concern with an estimated incidence of over 2 lakh cases worldwide per year. And common belief among the researchers and clinicians is that the ruptured ACL has a limited healing capacity. However, the recent studies suggested that the certain non-surgical intervention like CBP can promote the natural healing of an ACL. The CBP involves immobilizing the knee at the 90-degree of flexion using a brace for an initial period, typically 4 weeks. Following this immobilization phase, the protocol includes a physiotherapist-supervised rehabilitation exercises along with the TECAR. TECAR is a therapeutic modality which has been shown to improve the healing. The present case report aims to document the successful application of a cross-bracing protocol and an MRI-based monitoring of ACL healing in a young basketball player with full-thickness ACL tear. So our research question was, does the cross-bracing protocol influence the healing process and functional recovery in patients with complete ACL tear? So patient information, a 19-year-old male basketball player presented with a chief complaint of right knee pain, limited range of motion, swelling and instability following a non-contact injury during a basketball match. Initial evaluation revealed a positive Leishman test and pivot shift test, and MRI confirmed a complete ACL tear. So the mechanism of injury was, basically the mechanism of injury for the ACL are of two types, that is contact injury and non-contact injury. As we have saw the previous study, non-contact injuries are the commonest one, which are 70%. So in our case, it was non-contact injury, single leg landing, in which the knees goes into flexion, tibial rotation, and excessive valgus forces. Clinical finding, physical examination. First one is the pain. Onset was sudden. Site was right knee, posterolateral aspect. Intensity was 8 on 10 on activity and 5 on 10 on rest, which was taken on NPRS, that is numerical pain rating scale. Duration was acute and type of pain was dull aching. On inspection and palpation, warmth was present, swelling was present, and tenderness grade 2 was present. Special tests which were taken was Leishman test and pivot shift test. Both these tests have good reliability and sensitivity in case of ACL tear. So intervention was given for the 10 weeks by placing the knee into 90 degree of flexion within the knee, and gradually the degree of flexion was changed. For the first 4 weeks, knee was fitted and locked at the 90 degree, and patient was not allowed to bear the weight on the affected limb. Physiotherapy, supervised rehabilitation include the manual therapy weekly, maintaining the knee at 90 degree of flexion. Cryotherapy was given for the pain relief, and rehabilitation exercises which were given was quadriceps and hamstring co-contraction, plantar flexion with TheraBand, hip abduction extension, contralateral limb strengthening, which includes single leg press, extension, hamstring curl, calf raises, glute bridge, and core activation. Upper body strengthening was also given, and TECAR, which was given twice a week. For week 5 to 6, the degree of flexion was changed from 60 to 90 degree of flexion. In week 6, 45 degree to 90 degree of flexion and extension was allowed. Manual therapy was given. For the manual therapy, breast was taken off, and the previous exercises were continued along with the ankle weights. For the week 7, 30 degree of full flexion, and week 8, 20 degree of full flexion 20 degrees to full flexion were allowed. With the manual therapy, along with the previous exercises, gait training plus wall squat plus body weight squat within the brace limit were progressed. For week 9, 10 degrees to full flexion were allowed, along with the knee range of motion exercises, Pilates, body weight squat, bridges, crab walk, calf raises, and static balance exercises, and cycling was also given if he was able to achieve the 100 degree of flexion. Upper body strengthening was also given. For week 10, full flexion, that is unrestricted range of motion, was given without the breast, and progressive strengthening of the affected limb was taken. So my outcome measures were MRI, pain, quality of life. MRI was assessed by pain rating scale, and quality of life was taken on IKDC, that is International Knee Documentation Committee score. The score is taken from 0 to 100 degree. Less the score, less the functional activity of an athlete, and more the score, more is the functionally active an athlete is considered. As you can see in graph 1, the IKD score on day 1 was around 40, which was increased till the week 10, and it went up to the 85 out of 100. Same on the NPRS. When patient came on the first day, the pain was around 8 on NPRS, which was gradually decreased till 10th week, which was 2 on NPRS. Results. So the MRI was taken prior the intervention and post intervention, that is after 3 months. In the first picture, as we can see, there were first MRI was taken on 18/6/2024, in which there is complete thickness of ACL tear along with the buckling of PCL and moderate joint effusion. The second MRI, which was taken after the intervention of 10 weeks of cross-bracing protocol, second was taken on 4/10/2024, which shows partial thickness of ACL along with the mild joint effusion. So discussion. The case study found that the person with acute ACL rupture who were managed with a novel bracing protocol involving immobilization of knee at 90 degree of flexion had evidence of ACL healing on 3-month MRI. Anatomical studies have demonstrated that ACL has rich blood circulation. Distance between the ACL origin to its insertion is shortest at 90 degree to 135 degree of knee flexion, so that we chose the 90 degree of flexion in the breast, because this was the in this position the distance between the torn ligaments end was reduced. So the novel cross-bracing protocol that aims to reduce the gap distance that the ligament remnant by immobilizing the knee at 90 degree of flexion for 4 weeks after acute ACL rupture in attempt to facilitate the bridging of tissue and healing between the ruptured ACL remnant. TECAR Tegar therapy is known for the diminishing muscle spasm, improving blood flow, enhancing muscle oxygenation, activating the body's natural healing mechanism, and reducing inflammation. So conclusion of our study was, after managing the ACL tear with cross-bracing protocol, patient had evidence of ACL healing on 3-month MRI and also showed recovery in functional outcome measure that were IKDC and NPRS. These were the references. Thank you.
Strength of your case report.
This is strength if patient is not, in our case, the subject which were included was with complete ACL tear. If sometimes complete ACL tear, the orthopedician suggests that you should go for the surgical intervention, but if he's not able to go for surgical or if he's hesitant, so we can advise him to go for a 3-month cross-bracing protocol. And if he shows the positive results, just like from complete to partial, then we can progress the rehabilitation. So the strength is we can avoid the surgery.
But for cross bracing, what are the functional limitations to the
Yes,
patient?
sir. Some functional limitations are there. Just like in the previous 4 weeks, he's not allowed to bear the weight on the affected limb, and he was able to walk with the crutch only. So there are some limitations like this. And another limitation of this study was that healing changes from individual to individual. In our study, the patient was of 19 years old. So the healing is like more in the younger age. But if we take the patient of 35 age, the healing can be hindered. Thank you.
Next will be PA7.
Should I start? Good afternoon, everyone. The title of my project is the Effectiveness of Upper Extremity Proprioceptive Training on Reaction Time in Batsmen, an experimental study. So, popular sports and it requires the quick reaction time and precise movements. Yes. Cricket is one of the popular game, and it requires a quick reaction time and precise movements. So particularly in batsman, that he has a role of hitting the ball thrown by the opposite team. So in batting is known to be an integrated combination of a mental, perceptual and technical skills. There are 2 types of batsmen, right-handed batsman and left-handed batsman, and different types of shot batsman has to play. So example, block, cut, sweep, drive, edge, pull. There are different types of shots batsman has to play. So taking example of a sweep and a drive pattern. So in a sweep pattern, batsman has to move the bat in a horizontal direction, and in a drive pattern, batsman has to move his bat on a vertical direction. So different types of shots batsman has to play. The fastest bowlers often bowl around 150 km per hour. This will give a batsman less than 0.4 to 4 seconds to react. So it is a very shortest time batsman get to react. As the proprioception get affected, performance of the player during the sports is also get affected. Reaction time is a time period between the detection of the primary stimulus to the movement where you begin the body response.
Reaction time are divided into three basic types. Simple reaction time, in that one stimuli and one response is there. Choice reaction time, in that multiple stimuli and multiple responses we have to perform. And in recognition reaction time, there are multiple stimuli, but only we have to play one shot. So factor affecting the reaction time are age, gender, arousal, fatigue, distraction, stress, intelligence, and left and right hand. So this is a simple GIF. In that, the ball primary stimulus is the bowler throwing the ball in front of the towards the batsman, and batsman has to lay. So very short period of time a batsman has to get. Proprioception is a subsystem of a somatosensory system. It is a sense of position and movement. So it includes the joint position sense of a movement, sense of a force, and sense of a change in a velocity. It is an important sensory function for all normal mobility actions, including administering the dynamic balance and the skill of moving in the right manner. Proprioceptive training is to develop the proprioceptive senses, which is found in the muscle, joint, and ligament. As the proprioception get affected, the performance of the player during the shot is also get affected. So the need of the studies, the cricket is one of the fast ball game. It is characterized by a perceptual uncertainty and the time pressure, and hence the players require a short reaction time for the success. Reaction time can be improved by the exercises, but there are less evidence on the different types of exercises that can be used to improve the reaction time in cricket. Proprioceptive training following the lower extremity is commonly recommended, but there are a few informations on the proprioceptive on the upper limbs, and there are a few informations on the improving the reaction time in batsman. And proprioceptive training exercises are not included in the daily regular training in cricketers. The aim of the study, to study the effectiveness of upper extremity proprioceptive training on reaction time in batsman. Methodology, study design, pre and post study, sample size were the 33, sample method convenient, study population cricket children between the age group 12 to 16 who are going to cricket practice, study setting, cricket academy in and around Pune, study duration were the 6 months, duration of the intervention 3 weeks, thrice a week. Criteria, inclusion criteria were the age group between the 12 to 16-year boys, no any case of a visual or auditory impairments, willing to participate, MMT of a upper limb grade 4 and above, subject those who are not using spectacles and lenses, subject who are going to cricket practice regularly. In exclusion criteria, recent fracture or injuries to the upper extremity, not willing to participate, those who are not obey the commands, and those who are taking the specific training other than the cricket during the testing period, and those who are involved in other gym activities during the test period. The exercise protocol, so for the control group, they are involved in only normal fitness training, and in proprioceptive training group, the fitness training with proprioceptive exercises were given. So following these are the exercises I have included I have given. So in week 1, the rhythmic stabilization, quadruped, knee push-ups, prone on elbow, and push-ups. These 5 exercises were given, and the progression was with hold and repetition. The progression was progress according to the increasing hold and repetitions. And if, in week 2 and 3, the 3 exercises are added. So the 3 exercises are hands on wobble board, elbow on gym ball, and hands on gym ball. So these are the pictorial representation of the exercises. So for outcome measure, for measuring the reaction time, ruler drop test is used. And for reaction time is calculated using the formula, that is T equals to square root 2D upon G. So in this, T is a reaction time in seconds, D is a distance at which the ruler is caught, and G is a gravitational force. The result, the data were collected, was statistically analyzed using Microsoft Excel. sheet and the graph pad. Paid test was used to get the difference between the pre and post values. The various statistical measure such as mean and SD test of a significance were utilized to analyze the data. The result were concluded to be statistically significant if the p-value is a 0.05. So the first pie diagram is showing that the distribution of the age groups. So in that the 14 and the 15 age group criteria where the population is more. In the second diagram, the pre-treatment mean is a 2.456 and the post-treatment mean is a 1.876. So it shows that it reduces. And in the table, the p-value is showing that the less than 0.0001. So result showing that it is extremely significant. Discussion. The objective of the study was to find the effectiveness of reaction time in batsmen by upper extremity proprioceptive training exercises between the age 12 to 16 years. Proprioceptive training is a type of a training that focused on enhancing an individual awareness of their body position and movements. This type of training has been shown to be effective in improving reaction time in variety of sports. And the one study was done on the effectiveness of proprioceptive in a tennis players. And another study is also done on the proprioceptive training on handball, but the outcome measure is on performance, to increase the performance. Proprioceptive exercises are activities that challenge and improve the senses, sense its position, movement and orientation in space, typically through the movement that require balance, coordination and body awareness. Improved proprioception can help to reduce the risk of injury and improving the balance and stability. So it enhances the body's ability to react as quickly as possible and appropriately in sudden movements or if there is a change in direction. So it helps. So the conclusion of the study is this study concludes that the proprioceptive exercises are significantly beneficial in improving the reaction time in batsmen. Following are my references. Thank you.
Can you repeat the procedures, what you have done? Procedures,
yes,
intervention.
First I go to the academies and I taken the consent and assent form from the participants, and then I pre-assess with the help of a ruler drop test, and I recorded the data, and then I divided them into two groups. So for control group, I didn't given any exercises. They are involved in regular fitness training only. And for proprioceptive training group, I have given the proprioceptive training exercises with their regular
only
fitness
ruler
training.
drop test.
Sir, so ruler drop test, I have a diagram. So in
show that, because how it is related to the batting means?
So
Reaction
ruler
time.
drop test is only to only to calculate the
But you
reaction
have
time.
shown in discussion that it's related to the handball activity and this type of sports. How we can relate, and what was the functionality of this test?
Yes. So sir, there is no any tool to means there are tools to calculate the reaction time, that hand-eye quickness. So
But it will be
light
better if
eye
some
time.
video recording or something, batting functional test, it will
Yes.
be more feasible, better correlate with your outcomes.
Yes sir, but that time it is a feasible and it is no cost and it is available. Thank you.
PA8.
Good afternoon, everyone.
My topic is evaluating the efficacy of manual lymphatic drainage, stretching, conservative exercises, and home-based interventions on quality of life in patient with axillary wave syndrome, a case report. Introduction. The breast cancer is the most common cancer in women due to the lack of estrogen in a postmenopausal woman. It is more commonly seen in them. Amongst women undergoing the breast cancer treatment, axillary wave syndrome emerges as a prevalent complication often observed within an early post-operative period, occurring within the 8 weeks after the axillary surgery. The axillary wave syndrome is described as a presence of visible or palpable cord-like subcutaneous tissue. It mainly emerges beneath the axilla but may extend towards the inner arm and potentially reaches down to the antecubital fossa. The axillary wave syndrome causes the pain during the shoulder abduction and flexion, resulting in the loss of functionality and restricted mobility in the affected upper limb. The mechanism of underlying development of the axillary wave syndrome involves iatrogenic damage to the lymphatic and the venous system during the breast cancer surgery. These damages leads to the local stasis, hypercoagulation, and inflammation of the affected superficial vein and the lymphatic vessels. The numerous case reports suggested that the range of interventions include the patient education, active shoulder exercises, therapeutic massage with passive shoulder movement, and the fascia mobilization technique, alongside the physical therapy, applying the moist heat on the axilla and the inner arm, along with the arm exercises and utilizing the shoulder exercises with a cohesive bandaging. The manual lymphatic drainage therapy is a specialized massage technique is designed to stimulate the lymphatic system, facilitating the removal of the excess of the fluid secretion and the metabolic waste product, thereby reducing the edema and promoting the tissue healing. The clinical presentation: the 62-year-old female healthy woman was diagnosed with the left modified radical mastectomy with removal of the 6 axillary lymph nodes on the non-dominant side, that is on the left side. Within the 20 days of the surgery, she presented with the axillary wave syndrome extending distally down to the upper extremity and proximally through the breast and the trunk wall. She conveyed the discomfort when elevating the left shoulder and described experiencing the pain from her left armpit to inner region of her left arm. The physical examinations are the string-like cord were observed and failed on the inner arm when the shoulder was raised on the same side. The intensive pain which moving her left shoulder away from her body. The shoulder range of motion is decreased from 180 degree to 110 degree as assessed using the goniometer. There is no sign of inflammation such as redness and warmth. On the visual analog scale, she rated her pain 9 on 10. Throughout the follow-up period, the patient experiences the numbness and tightness. Her body mass index is 29.5 on kg per meter square. On inspection, 12 centimeter subcutaneous band or cord are observed that extending from the left armpit to the inner side of the left arm. Interventions are in phase 1, that is 0 to first week. Initially the goals are to reduce the pain and discomfort, to improve the range of motion, and to promote the lymphatic drainage. For the reduction of the pain, the hot fermentation are given for that 2 to 3 sessions throughout the week. To improve the range of motion, initially 10 minutes of warm up and cool down exercises, cool down period, and stretching of the pectoralis major, pectoralis minor, bicep brachii, tricep brachii, and the latissimus dorsi muscles, and the active shoulder exercises like shoulder flexion, abduction exercises. The dosage of exercises are 1 to 3 sets of 5 to 10 repetitions, 1 to 3 times per day. To promote the lymphatic drainage, the manual lymphatic drainage technique applying the desorption stroke on the taut cord that progressively enhance their flexibility, mainly on the axilla and the medial aspect of the arm, that progresses from the proximal to the distal third of the arm. The specific thumb manual lymphatic drainage therapy on the taut cord according to their characteristics and size of the axilla to the forearm, on the axilla and the proximal third of the arm. In the phase 2, that is 2 to 3 week, that initial goal is enhance the strength and stability, which mainly focuses on the shoulder flexors, shoulder abductors, and the elbow flexors, strengthening elbow flexors muscles. The dosage of that exercises are the 3 sets of 10 repetitions using the TheraBand, 6 to 8 on omni resistance. And we can also give the PNF technique, the proprioceptive neuromuscular facilitation exercises in the diagonal pattern. The dosage of that exercises are the 3 sets of 10 repetition using the TheraBand. The phase 3, that is 3 to 4 week, the initial goal is enhance the flexibility and the functional use. For that, the butterfly wing exercises and the child pose and seated ball push up forward. The dosage are the 10 repetition and the 5 seconds hold. In phase 4, the home-based interventions are given. For that, the self-stretching exercises is advised to the patient, and the stretching exercise, that is corner stretch, T and Y stretch, and the chest stretch. And also we can advise the lymphatic therapy exercises, performing the breaststroke type of movement for 15 minutes twice a week. The results are given. Initially when the patient is came, he rated 9 on 10 on VAS scale, that is visual analog scale. After the mild lymphatic drainage exercises, he rated the 6 on 10. After the stretching and conservative exercises, he rated 3 on 10, and on home-based intervention, he rated 0. Same for the range of motion. Initially patient is came, his range of motion are 110 degree of shoulder abduction by using the goniometer. After the manual lymphatic drainage, his range is 120 degree. After stretching and conservative exercises, his range is 150 degree, and after the home-based intervention, his range was improved up to the 170 degree. Same for the muscle strength. Muscle strength is taken from the MRC grading. On initially his grade is 2. After the manual lymphatic drainage, his grade is 3. And same for the stretching and the conservative exercises, and his grade is increased up to the 4 by the home-based interventions exercises. We also taken the outcome measure as a breast cancer specific quality of life score, that is European Organization of Research and Treatment for the cancer patient. It is ranged from 0 to 100. Initially his score is 50. After the MLD, his score is 60, and stretching and conservative exercises is 80, and after the home-based intervention, his score is 90, that is increased. Initially on graph number 1, the visual analog scale is taken. As described previously, same is for that. At baseline, the patient reported the pain 9 on 10. Discussion. The case report demonstrated that the positive outcome of the comprehensive rehabilitation strategy, including the manual lymphatic drainage, stretching, conservative exercises, and home-based intervention in enhancing the quality of life for a patient with the axillary wave syndrome. After the post-MLD session, pain was reduced and tension in the affected area. The benefits of the manual lymphatic drainage in elevating the lymphoedema and associated symptoms, on reducing the lymphatic congestion and promoting the fluid drainage, that effectively reduces the lymphoedema volume and improve the quality of the life in the breast cancer patients. After the stretching and the conservative exercises, he restore his range of motion up to the 170 degree of the abduction, that breaking the fibrotic cord and enhancing the tissue elasticity. Regular stretching and targeted exercise significantly improve the shoulder range of motion. Home-based interventions include the self-massage, regular stretching, and low-intensity exercises to the patient rehabilitation program. That effectiveness of the home-based intervention program is maintaining the arm function and reducing the axillary wave syndrome symptoms. The limitation are, while result in this case report are promising, several limitations must be acknowledged. The findings are based on the single patient experiences, which limits the generalization of the result. Further research should be include the large sample size and diverse patient population to validate their finding. Additionally, the long-term effect on combined intervention on the axillary wave syndrome need further exploration, and we can also do the randomized control trial on the maximum population. Conclusion: the case report underscored the efficacy of the comprehensive approach, including the MLD, stretching and conservative exercises, and home-based intervention that improve the quality of the life of the patient in the axillary wave syndrome patients. These are all the references. Thank you.
Axillary web syndrome. So how will you recognize in normal, means post breast cancer patients?
It is all taut-like cord is observed on the armpit region when patient doing the abduction or overhead movements of like flexion and abductions, and she has a stiffness in her shoulder joint, and her range of motion.
What is the prevalence rate of
What's
this
that?
syndrome? Prevalence rate of this syndrome of post mastectomy.
Prevalence.
Yeah.
Sir, it is a case report.
But in an introduction you have written somewhere.
Yes, sir.
You should know how frequent it is. And what is the strength of your case report?
What, sir?
Strength. What is the strength? Unique things you have included.
Sir, I focus on the manual lymphatic drainage along with the stretching exercises, conservative exercises, and home-based interventions in which the aquatic therapy are Thank you, sir.
We are done with the all paper and poster presentation. We'll wait for the 5 minutes, and after that Webo sir will declare the results. Thank you.
the presentations were very helpful for the sports aspects, sports domain. All the presentations were very good. Some RCTs were also presented. That is very good in hierarchy. Means if you see the research domains as a whole, the review having the peak most valid tool, but whereas RCT having a also important role. Some students have presented case reports also, and that is very good thing. All the presentations have gone smoothly and nicely and on time. I request Payal to declare only because we both have decided and she will declare the results.
Thank you, sir. So now I request Sabi sir and Webo sir to present the prizes to the students. We'll go with the poster presentation first. The second prize goes to PO2. And the first prize is PO3. Then for the paper presentation, the third prize goes to PA8. The second prize goes to PA5. The first prize goes to PA3. I request all the winners to come forward for the group photo. Yeah, but first we'll take with the winners and then with the participants. वो flyer जो बनाया था ना हमने पहला वाला फोटो का एक रिंकल नाम का और एक flyer का scientific presentation का जो flyer है ना उसको display कर दिया. हाँ हाँ हाँ. So I have one announcement that the certificates for the winners will be digitally mailed you after the conference. And then as we conclude this enriched scientific session at IMA National Sports Conference 2024, I extend heartfelt gratitude to our esteemed judges, Dr. Weber and Dr. Sabi, for their expert guidance. A big thank you to all presenters for sharing your impactful research, and to the MGM Institute of Physiotherapy and MGM School of Physiotherapy for their invaluable collaboration. To the organizing team, the volunteers, your hard work ensured that session success, and to our audience, your engagement made it more all vibrant. So thank you each and everyone present over here. And now after like lunch, 2:30 the next session will be starting. Okay, so now there will be a lunch break. Thank you.
रेडी है सर.
सर रेडी आहे.
Hello all, we are back for afternoon session, and today's afternoon session is going to be opened by esteemed faculty. He is head of the Department of Orthopedics, Government Medical College and Hospital, CHHATRAPATI SAMBHAJINAGAR, Professor Dr. M.B. Lingayat sir. Dr. Lingayat sir is specialized in joint replacements, pelviacetabular surgeries, complex traumas, and spine surgeries. Today, for sports injury session, he is going to guide us about various kinds of ankle injuries, because ankle is the most unstable joint in lower limb, and it gets affected very commonly in badminton, football, or any contact sport which involves high force or high trauma to joints. So we will be listening to Dr. Lingayat sir. Sir, please come. Hey, relay kara. Link is going on, yes.
Good afternoon all. As organizer Dr. Akshay says that many of the delegates are online, so I start my lectures. My lectures is given by organizer on the ankle injury. You know the famous cricketer Pujara, who has injured his ankle joint while playing a test match, and another famous cricketer, Dr. Hardik Pandya, injured his ankle while playing cricket. So as Axis says that this is a common injury which occur during the various sports, cricket, badminton, football. So before giving a lecture on the ankle injury, we should know about something anatomy of the ankle injury. It is a synovial joint of hinge variety. Shape of the articular bones, strength of the ligaments and the surrounding tendon make this joint strong and stable. Upper articular surface is formed by the lower end of the tibia. Lower articular surface is formed by the dome of the dome of the talus. It also includes the medial malleus and the lateral malleus. So these are the various articular surfaces of the ankle joint, that is showing the talus. So this is most important. The ankle joint is mostly supported by this ligament. These are the capsular ligament, medial collateral ligament and lateral collateral ligaments. Capsules is attached all around the ankle joints except posteriorly, where it is attached, posterior superior it is attached to the inferior transverse tibiofibular ligaments, and anterior inferior attached to the dorsum of the neck of the talus. Rest of the things is whole covered by the capsule. It gives strength to the ankle joints. Medial ligament, another name for the medial ligament is a deltoid ligament. It is having two parts, that is a superficial part and a deep part. Superficial part divided into three parts, that is anterior fiber, that is a tibio-navicular ligaments, medial fibers, that is tibio-calcaneal ligaments, posterior fibers, that is posterior tibio-talar ligament. The deep part is anterior tibio-talar ligament attached to the anterior part of the medial surface of the talus. Lateral ligament, you label that I am having an ankle sprain, means it is a most of the time it is a lateral ligament injury. It is having three parts, that is anterior tibiofibular ligament, calcaneofibular ligaments, posterior tibiofibular ligaments. These are the three parts which are included in the lateral ligaments. Syndesmosis. Syndesmosis is another important component of the ankle joint. It is a fibrous joint that connects two bones with the ligaments or a strong membrane. Ankle syndesmosis is formed by the anterior inferior tibiofibular ligaments, interosseous ligament, interosseous membrane, posterior tibiofibular ligaments. Blood supply of the ankle joint is mostly it is derived from the branches of the anterior and posterior tibial and peroneal arteries. Nerve supply is mostly through the deep peroneal nerves and the tibial nerves. Sometimes it is supplied by the superficial peroneal nerve also. Ankle injury try to divide into two parts, that is ankle sprain, which includes the injury to the ligament, various ligament, that is medial ligament, lateral ligament, and a syndesmotic injury. And second part, if the injury severity is more, it lead to the ankle fractures. The ankle fracture is the break of the one or more bones surrounding the ankle joints. Ankle sprain. What is ankle sprain? Ankle sprain. Why ankle sprain commonly occur? Because ankle joint transmit 1.5 times of the body weight when walking and 4 times of the body weight when running. Ankle sprain is the injury to the ligamentous structures that surround the ankle joints. Most common soft tissue injury affecting the nearly 40% of the sports injury. What are the types of ankle ligament injury? This is lateral ankle ligament injury, which is most commonly occurs. Second one is a syndesmotic injury. Third one is a medial ankle ligament injury. What is lateral ankle ligament injury? This is the injury to the three of the ligaments, that is anterior talofibular ligament, calcaneofibular ligament and posterior talofibular ligament. Among these, the anterior talofibular ligament is commonly injured, followed by the calcaneofibular ligaments. So this is a mechanism which showing the injury to the lateral ligaments while playing the basketball, and second one is while playing the cricket, which teaches these ankle joints and injured the lateral ligaments. Syndesmotic injury is the second most common injury next to the lateral ligament. It is a inferior tibiofibular syndesmosis, anterior tibiofibular ligament, posterior tibiofibular ligament, transverse tibiofibular ligament, interosseous ligament. Primary functions of this syndesmotic ligament is maintain the stability between the tibia and the distal fibula. Mechanism of injury is externally rotated and dorsiflex foot while playing any of the games. Anterior tibiofibular ligament is most commonly injured in the syndesmotic injury. Medial ligaments. Medial ligament injury is next to the syndesmotic injury. It injury to the deltoid ligament, tibionavicular ligament, tibiocalcaneal ligament, anterior tibiotalar ligament, posterior tibiotalar ligament. Primary function of this medial ligaments is limit the eversions. So whatever the eversion occurs, excessive eversion leads to the medial ligament injury, that is deltoid ligament injury. Strongest ankle ligament among the three ligaments, this is the strongest ankle ligament. That's why it is a third in injury sequence. First one is the lateral ligament, second one is the syndesmotic ligament, and third one is the medial ligament. How it occurs? This is our Hardik Pandya, which injured his medial ligament while playing a cricket or while doing a bowling. See, the ankle is twisted, everted, and injured the medial ligaments. Once you get this injury, what things has to be done? We have to do the special test, that is talar tilt test, that is inversion test, calcaneofibular ligament, external rotation test, that is for syndesmotic injury, anterior dorsal test for anterior talofibular ligament, and squeeze test for syndesmotic injury. So this is demonstration of anterior drawer test. When there is a excessive shifting of the talus over the tibia as compared to the opposite ankle joint, that means that the positive anterior drawer test indicate that the ligament injury is there. Talar teeth, commonly you are not able to do the inversion of the foot as compared to the normal ankle joint. If it is excessive as compared to the normal ankle joint, then it indicates that he is having a ligamental injury. So this is all for lateral ligament injury. These are the special tests for syndesmotic injury, that is a squeeze test which indicate the pain at the ankle joint, indicate the syndesmotic injury. Dorsiflexion and external rotation test, if patient is having pain at the ankle joint, indicate the syndesmotic injury. This is a demonstration of the squeeze test for the syndesmotic injury. This is another demonstration of syndesmotic injury, how to diagnose the syndesmotic injury. What investigation will do in the ankle injury? This is a plain X-ray, stress film radiograph, CT, MRI, ultrasound, and MRI orthography. This is Ottawa rules, which is commonly applied to the ankle joint. This is for when to do the X-ray in the ankle injury. Ankle series is only indicated, or ankle X-ray is only indicated for patient who have pain in the malleolar zone, either medial malleus or lateral malleus. Having a bony tenderness at the posterior edge of or tip of the lateral malleus or medial malleus. Are unable to bear weight both immediately after the injury or 4 steps in the emergency department or doctor's office. A foot X-ray is indicated for patients who have pain in the mid zone and have a bony tenderness at the base of the fifth metatarsal or navicular, and unable to bear a weight both immediately after the injury and 4 steps in the emergency department or doctor office. So these are the normal X-ray. This is the AP view, this is a oblique view, and this is a lateral view. So if this X-ray are normal, still the patient is having pain, then you can advise a stress view. That is, you have to do the dorsiflexion of the both ankle joint and take a X-ray. If normally there is talar shift from the posterior tibial dome or posterior articular surface is more than 5 mm, then it indicate that the lateral ligament injury is there. Similarly, inversion X-rays are taken. If their excessive angle is more normal, talar tilt is more than 5 degree, is indicate that the patient is having lateral ligament injury. Ultrasound is indicated ankle injury having a sensitivity of 92%, but specificity is only 64%. Advantage is dynamic diagnostic study and cheaper price. Operating depending difficult in high subcutaneous patient or fat patients. It is difficult to diagnose in the fatty patients. CT requires if you are suspecting a fractures or doubtful on the X-ray, then CT is indicated. MRI is a choice of investigation in the ankle injury, but don't ask to do the MRI in acute phase, initial 8 to 10 days, because you have a misleading findings because of the hematoma. It is having 93 to 96% specificity and 100% specificity. So these are the MRI finding showing the lateral ligament injury. After doing all the X-rays, you have to grade the patient to treat for the treatment purpose. What is grade 1? The loss of function is no loss of function in grade 1. Ligamental laxity is negative by doing an anti-drawer test or inversion and eversion test or a stress test. Ecchymosis little or none. Ankle motions decrease by less than 5 degree. Swelling is less than 0.5 centimeter or very minimal swelling is there. What is grade 2? Loss of function is partial loss of function. Ligament laxity is positive, that is anti-drawer test is positive, but talar tilt test is negative. Ecchymosis, some ecchymosis is there around the ankle joints. Ankle motions moments are decreased by 5 to 10 degree. Swelling is there, moderate swelling is there, then you will label this injury as a grade 2 ankle injury. What is grade 3 ankle injury? Loss of function, near total loss of function, patient is unable to bear a weight, he has to take a support of some persons. Ligamental laxity test, both anti-drawer test and talar test are positive. Ecchymosis, there is extreme ecchymosis is there. Ankle movements are decreased more than 10 degree. Swelling is there is excessive swelling is there. So this is the grading of the ankle injury. This will be helpful for treatment purpose. Treatment in acute phase is a protected motion phase of rehabilitations. Then it progressive loading and sensorimotor training phase. Acute phase 72 hours following the injury. Subject with the significant edema, pain and limited weight bearing or ward gait elevations. Progressive loading and sensorimotor training phase post acute period with primary concern of weakness, balance responses. Intermittent edema includes the study that enroll the subject with mechanical or a functional ankle instability. How will treat the acute phase? This is a RICE. I will explain what is this RICE. Then some pharmacological drugs, non-pharmacological treatment and surgery. What is this RICE? RICE is a rest, ice application, compression dressing and elevations. If the patient is having ankle injury at the time of sports, playing the sports, so first thing which has to be done is give the rest to that ankle joints. Apply if ice is applicable, available at the site of the injury, then apply the ice. Then do the compression dressing and keep the leg elevated so that the swelling will not occur or ecchymosis will not occur. Pharmacological treatment, this some NSAID is prescribed. Oral or topical NSAID is advised. Sprays are available usually at the time of sports. So use of NSAID is a little bit controversial that it delayed the ligament and healing. So whether to use the NSAID or not, it is a controversial issue, but if the patient is having acute pain, in that condition one has to use some NSAIDs. Non-pharmacological treatment is therapeutic exercises, immobilization by some of the cast or splint, functional support with using the some splint and other therapies. If your patient is having grade 1, grade 2 ankle injury, one can advise the peroneus muscle strengthening exercises. This is dorsiflexion and palmar flexions. This is inversion and eversion. These are the isometric ankle exercises. These are indicated once the acute phase is subsided. So these are the functional supports. For minimum period is advisable if the patient is not responding to the conservative NSAIDs, having a grade 1 or grade 2 injury. In that case, the patient will require some functional support for with early weight bearing. Ankle brace is there, kino steps is there, compression stocking are there. Other therapy which is indicated or which is described in the books for the ankle injuries: ultrasound, laser therapy, electrotherapy, shortwave diathermy. No effect on pain, edema, function and return to the function. Acupuncture inconclusive is there. Local vibration therapy is also not useful. This is the paper which is says that use of ultrasound or shortwave diathermy, acupuncture or local vibration therapies have very little or no role in ankle injuries. When you do a surgery in acute injury, if there are recurrent sprains are there, failed conservative treatment, concurrent ankle pathology requiring surgery, example associated malleolar fractures, and high performance athletes. In this case, we advise the early surgery. For example, type 3 injuries in athletes, we advise the early surgery, or otherwise, if the patient is having associated with the fractures like this, in that case, we advise the surgery. This is fixed by the malleolar screw. These are the screw which are put into the medial malleus along with the repair of the medial ligaments. After this treatment, what is advised or rehabilitate? Advice in the rehabilitation is some NSAIDs. Sometimes the hyaluronic injections are given in the type 1, type 2 injuries, and sometimes PRP, the plasma rich proteins or injections are given in the ankle injury. Non-pharmacological therapeutic exercises and activities, functional exercises and activities, balanced training program, proprioceptive exercises, sport-related activity training, exercises therapy had protective effect compared with the usual care. Indication for surgery: surgical repair in cases of ankle injury. When the ankle injury is chronic, became sick more than 6 weeks or 3 months, not responding to any line of treatment, like that is your NSAIDs, your exercises treatment or other treatment, then one can advise a surgery for that. Before that surgery, one should do a confirmation of the ligament injury by doing a certain investigation like MRI. Only 10 to 30% of sprains have a chronic symptoms that will require the surgery. If patient is having a mechanical abnormality while walking, anterior translation or varus tilt, having a sensation of giving away at the ankle joint while running or walking, and recurrent sprains episodes are the indication for surgery. How surgery is done is anatomical repair. Anatomical repair is indicated when there is avulsion injury. In cases of there is a avulsion of the ligament from the bony fragment, in that case anatomical repair is possible. Broston, Gould, anti-tibial and calcaneal repair after restoring the tensions, inferior extensor reticular reinforcements, and ligament reconstruction using the Marcelin tape. These are non-anatomical things which are used for replacing the lateral ligaments. Why I am describing the lateral ligament? Because this is the most common ligament which is get injured in the ankle injury. This is non-anatomical reconstruction, means you take a surrounding tissues, that is the tendons which are there around the ankle joints. In this case, they are showing the peroneus brevis tendon, which is used for reconstruction of the lateral ligaments. This is my own patient. He is a kabaddi player. While he injured his ankle joint while playing a kabaddi, and having a chronic ankle injury, taken all sort of treatment in the form of NSAIDs, scrape, cast, exercises, but no relief. So I advise the surgery for that, and I do a non-anatomical reconstruction using a peroneus tendon. This show some hole in the fibula, that passing the tendon in the lateral malleus, and these are the functions of the patients. After the ankle injury or a ligament injury, the second comes with the ankle fractures or fractures around the ankle joints. So this occurs when the inversion or eversion is more significant or severe degree. It will lead to the fracture around the ankle joint. That is fracture of the medial malleus and lateral malleus. This is commonly called as a POTS fractures, and it is classified by AO or Weber classification or other classification which is used is the Hansen classifications. So this will not useful for you people. So this is a POTS classification that is useful for the different injuries around the ankle joint. This is a Weber fractures. This is also used to describe different types of injury around the ankle joints. So what are the stable ankle fracture where we can conserve the patients? These are the fractures that have a concurrent mortisis that will remain stable during the fracture healing. Mortisis means this is a joint which remain concurrent during the treatment. This is very important. This is lateral malleus fractures, but the ankle mortisis is maintained. In that case, we can conserve this patient by applying a below knee cast or for the period of 6 weeks, and then follow the routine schedule for the ankle injury, that is rehabilitations. These are the unstable ankle fracture where we indicate we advise the surgery. You know that the ankle mortisis is disturbed. There is a fracture of the lateral malleus or lower end of the fibula. There is a fracture of the medial malleus with talar tilt is there. Okay, there is some syndesmotic injuries also there. Okay, in this case there is a indication primary surgery. Indication is primary surgery in such type of injury. This is my own patients which having going for the police training, and he injured his her ankle joint while running. These are the injury after the fall while running. This is a fracture of the lateral malleus. This is a fracture of the medial malleus. This is a additional, there is a syndesmotic injury is there, and talar tilt is also there. This is a lateral view of the same patient. These are the X-ray of the same patient after surgery, follow-up of 3 months. There is fixation for the syndesmotic injury. There is a fixation for the lateral malleus fixation, and there is a medial malleus fixation with the help of the plates and the screws. These are the different oblique view. This is the lateral view. These are the function of the patients. She is able to cross-leg sit. These are the post-op clinical photographs of the same patients. Management of unstable fracture, lateral slide fibula, broad length and combination is bridge with 3.5 DCP or a fibular nail. These are the different options which are used for the treating the fractures. We can use a plate, we can use a screw, we can use a tension band wiring. This is the orthopedic treatment. Most of the audience which are there on online may not aware of this treatment, but these are the different things which are used for the ankle fracture fixation. So we will learn about the ankle injury, how the ankle injury occurs, what are the different type of ankle injury, what are the different type of fractures around the ankle joint. Let's learn something about the how to prevent this or how to strengthen our ankle joint to prevent the ankle injury. So these are the different exercises which are advised to prevent the ankle injury. Stand on your toes, do the dorsiflexion and plantar flexion of the ankle joints. This will strengthen your syndesmotic ligaments and lateral ligaments. So these are the different exercises. We have to ask the patient to walk on the everted foot. You have to ask the patient to walk on the inverted foot. This will strengthen your lateral ligament. This will strengthen your medial ligaments. This will help to prevent to some extent, not necessarily that will 100% guarantee that the patient will not have an injury while playing the sports because of this exercise, but to some extent it will help to strengthen your ligaments and prevent the severe or reduce the severity of the ankle injury while playing. Now it is playing. Okay. So what are the tips for the prevention of the ankle injury? Warm up prior to any sports activity. Condition your muscle for the sport. Choose the athlete's shoes specifically for your foot type. Replace the athletic shoes when the tread wears out or the heels wear down. Avoid running and stepping on uneven surfaces. Any injury, whether it is a sports injury or any injury, willpower is very important. Patience is very important, and rehab part is very important. Have a patience, have a willpower and good rehabilitation. You have an example to recover, full recovery of the injury. So this is a classical example. Anybody's, most of the audience which are there online may be aware of this Rishabh Pant, who is having a severe injury during a road traffic accident, and now he is back on the ground. So thank you everyone. We are present in the auditorium and who are there on the online. And once again, thank you the organizers, specifically Dr. Dahipade Madam, Vikas Deshmukh Sir, my colleague, orthopedic colleague Dr. Akshay Marawar, and all the organizers who have given chance, and my colleague in the medical college, that is Sunil Deshmukh Sir, who have given me a chance to present my topic on the ankle injury. Thank you very much. And I wish very best wishes to all the organizers, because this is the first time SPORTSCON is occurring in the city of Sambhajinagar. I must congratulate the all organizing team of Sambhajinagar IMA and the national IMA team. Thank you.
I want to felicitate Dr. Professor Lingayat sir with a token of appreciation from IMA, CHHATRAPATI Sambhajinagar. Sir, please. So running on time, sharp time. Now is the person for whom introduction is going to be very short. But still I will try to manage in 2 minutes. If you have all the delegates online and offline, if you remember recent Olympics, where it was held? Paris. The Paris Olympics, the delegation of India was led by a renowned sports surgeon. Anybody knows his name? He is a renowned sports surgeon from Kokilaben Dhirubhai Ambani Hospital, Mumbai. He is Dr. Dinshaw Pardiwala. So the person who is a sports surgeon, who himself has operated sports celebrities for knee and ankle injuries, is going to be live today. So you are fortunate enough to listen to him, because we in our undergraduate days were not fortunate enough to listen to him. So he is an orthopedic surgeon who is head of the Department of Sports Injuries at Kokila Ben Dhirubhai Ambani Hospital, 4 Bungalows, Andheri, Mumbai. He is going to be live, and he is going to speak about and teach us about how to return to sports after ligament injuries. If your knee gets injured, ACL, PCL, if your ankle gets injured, so there is a prehab, surgical point or medical management, and every sports person wants to get back to sports because it is life for him. So what should be done and how to get back to sports as early as possible after injuries, just like Professor Lingay sir just showed. Rishabh Pant is back to cricket team. So how it was possible? So he is going to guide us about that. Are we live? So you are joined?
Okay, I'm live. I can see you.
Hello sir, Akshay here from Chhatrapati Sambhajinagar.
Hi Akshay, good to see you.
Yes sir. Am I visible to you? Am I visible?
Yes, you are. Thank you.
You are still not visible. Just I have introduced you in short. If you want something to add it, sir, please let me know.
No, nothing to add.
I will add, sir. He is my teacher. He has taught me arthroscopy. He is my knee surgeon. He has operated for my knee. He is my shoulder surgeon. He has operated for my shoulder. Sir, something should be added?
No. That's the maximum you can.
So he is the
I'm
humble guy. He is the.
Akshay, good to see you.
You can look at him. He is the smartest guy I have ever seen. Will that be fine, sir? Over to you. We are eager to.
Thank you.
We are eager to hear you. Thank you.
Thank you, Akshay. Thank you for the invitation to be participating in the meeting. I'm sorry I can't be there, but it's a real honor to present in front of all of you. So I'm going to take a topic that's very close to my heart, and that's ensuring that our champions remain champions. So we've got athletes who are going to play sports, and any injury is, I think, part and parcel of sports. But how do we as doctors, sports doctors, physiotherapists, surgeons, ensure that our champions remain champions even after an injury? I think that's important. So what are the strategies that we as orthopedic surgeons do to ensure that there's a successful return to performance following sports injuries? It's important to get our athletes back into sports, but can we get them back into performance? I think that's critical. So if we have to have our champions back as champions, then there are certain strategies that we need to follow. In the 2016 Rio Olympics, Vinesh Fogart had a very significant injury to her right knee. This was a knee dislocation that she sustained on the mat, and she had to be stretchered out from that injury to the Olympic hospital there in Rio. And then she flew down to Bombay immediately, and she had to undergo a multiple ligament reconstruction in the right knee. 4 days later, she received the Arjuna Award from the Prime Minister in a wheelchair, in a cast, and then returned back to wrestling training. And then 7 months later, she won a silver medal at the Asian Wrestling Championships. 2 years later, she won the gold at the Commonwealth and a gold at the Asian Games. And all of this was possible because of many different strategies that we as doctors use to ensure that our athletes can get back to sports as soon as possible. So what are these strategies to ensure a quick and safe return to sports following an injury in an elite athlete? And I'll go through each of these 7 different topics. Advanced diagnostic medical imaging, the decision-taking that needs to be done, the surgery, technological advances in our surgeries, orthobiologics and regenerative sort of medicine which has come in today, and then of course rehab, and also biomechanics and understanding advanced aspects of sports and movement science. So let's start with advanced diagnostic and medical imaging. In medicine, often we're taught that you need to be don't over-investigate your patient, go on a clinical basis, which is so true. And of course, we'll start always with a clinical evaluation. But unlike normal orthopedic patients where we may opt to treat them non-operatively initially, get an X-ray and an MRI only subsequently if needed, if they don't get better. In an elite athlete where time is so critical, you don't have the opportunity to wait. So take, for example, this fast bowler who had a relatively minor fall on his outstretched arm and who complained of pain and some tingling numbness in his hand. His symptoms were significant, but all his clinical signs in the shoulder were negative. And the MRI also came as perfectly normal. And here, when you clinically evaluate an elite athlete and you say, look, everything seems normal. In a normal patient, you may actually wait. But in an elite athlete, you want to do every investigation possible. And that investigation that we did detected that he had a pseudoaneurysm of his axillary artery, which was then giving him significant symptoms and which then required surgery. And then following that surgery, after 6 to 9 months, he returned back and has had a very successful return back to IPL level and international level cricket. Now, if we hadn't investigated him, we would have missed the diagnosis and we probably would have landed up with a major catastrophic complication to his career of cricket. So I don't think in sports and especially in elite athletes, you can ever over-investigate. You need to reach that diagnosis quickly. And if after your clinical evaluation and your basic investigations, you haven't reached that diagnosis, then you need to certainly jump in, do everything possible, scans, vascular studies, sonographies, and get the diagnosis. Unless you have a diagnosis, treating these patients, prognosticating them becomes difficult. Also, patients who've got early chondral wear. So often we find that patients will have a relatively mild looking injury on the MRI, like this patient who's got a relatively normal looking MRI, mild bone edema there. It's only when we do some more advanced studies, like this D-Gemric study, which is going to show the cartilage a little better, or a T2 map, which is again going to show the cartilage a little better, we'll see that what looked like a very minor chondral injury is actually quite a significant injury. It involves a large zone of the articular cartilage. And then we can prognosticate this a little better as to when his return to play and sports and performance is likely to be. Decision taking is also very critical, because it's not always that you need to do surgery. You can always treat many of these patients non-operatively, but deciding what you require to do, when you require to do it, whether non-surgical would be better than surgical, is a critical aspect. And we don't necessarily treat our elite athletes as we would our normal human beings. So take, for example, this fast bowler. He's a right arm fast bowler. He's, in the previous IPL match, created a record for 6 wickets. In the next match, he goes for a very aggressive, fielding maneuver to save 4 runs and dislocates his shoulder. And of course, his team members are applauding him there for saving those 4 runs, but he's dislocated his shoulder. This is his right shoulder, this is his bowling arm, and after a first-time dislocation in a normal person, we would normally treat this non-operatively. But if it's an elite athlete, and especially if that's their throwing arm or their bowling arm, this labral tear is going to cause problems. We can predict that it's going to cause problems. There's going to be a higher recurrence rate. There's going to be an inadequate anterior stabilization, which is then going to reduce his ability to bowl fast, and therefore the decision for a primary surgery. So this is not a decision that we would have taken for a normal human being. A normal person, first-time dislocation, we're almost always going to treat it non-operatively. But because he's a fast bowler, because he's a high-level athlete, and we know that this labral tear is not going to allow him to get back to his previous level of performance, we're going to then have to do an arthroscopic capsular labral repair, also known as a arthroscopic Bankart repair. And so here, we've stabilized it. We've got that tension in the anterior band of the anterior glenohumeral ligament. Sorry. We've stabilized his chondral injury there on the glenoid. And this is his best way forward to ensuring that he gets back to performance. Similarly, when you land up with muscle and muscle tendon tears, like this rectus femoris tear, a normal human being lands up with this tear. Typically, we treat it non-operatively. But if you've got a tendon avulsion, a rectus avulsion in a footballer like him, not repairing this means he's never going to get back to his original level of performance. And so repairing these muscle tendon injuries, which often in orthopedics we neglect in normal human beings, we really need to do in our elite athletes. Take, for example, this adductor longus avulsion. So this is a bony avulsion of the adductor longus in a badminton player. Again, in orthopedics, often in my residency years, we used to do these percutaneous adductor longus releases in our older patients with adductor contractures, and it seemed to give them no problem at all. But for a high-level athlete, especially if he's a badminton player, he needs to jump. He needs a really strong adductor in the hip. This is something that we would put in suture anchors and then repair. So muscle tendon injuries that don't necessarily cause problems in normal people will cause problems in high-performance athletes. And you'll see that many of our athletes in many sports will have these injuries and will need to undergo surgeries for them. Similarly, for certain ligaments, certainly, and also for certain ligaments, take for example ankle sprains. Ankle sprains often, normal people who've slipped and fallen, we treat ankle sprains without surgery. But for a high performance athlete, if he's got an ATFL, anterior talofibular ligament tear, if he's got a calcaneofibular ligament tear, a CFL tear, then these are ligament tears that we will primarily repair. These patients don't do well with non-operative treatment, especially if 2 of the 3 lateral stabilizing ligaments are torn. This, of course, is not an approach that we would normally use for our non-elite athletic patients. So we can see that we treat this population a little differently when decision-making versus non-operative and operative is concerned. Coming now to the surgery itself. Surgeries now tend to be minimally invasive, especially if it's possible and if it's an athlete. So take, for example, this goalkeeper. He's the national goalkeeper. This is a World Cup qualifying match. He's the captain of his team. This is the Maldives, and they're qualifying. He lands up with an injury to his knee, and it's a posterior cruciate ligament tear. A lot of other normal, persons with a PCL tear we would treat non-operatively, but a goalkeeper with a PCL tear that's significant in today's day and age, an arthroscopic reconstruction, as versus the older days when we did open reconstructions, is going to get him back. And this arthroscopic approach is used for almost every joint, every large joint. So whether it's the shoulder, the elbow, the wrist, the hip, the knee, the ankle, the subtalar joint, many other areas where we in fact would do an endoscopic approach also, especially in the foot and ankle. So all of these areas are now amenable to minimally invasive surgeries, and it's these minimally invasive surgeries which are less morbid, which will allow them to get back to their level of sports and get back to performance. We've also got technological advances that have ensured that these technological devices help us to achieve our surgical aims. We as surgeons can be good with our hands and we can be skillful, but if we don't have devices that we can do things with, and we don't have good vision that we can approach these joints with, because there's so little space in these joints, we may not be that effective. And so technological advances in medical devices for surgical repair, I think, are very important strategies, and these will keep advancing over time. Quite a popular new sport in Bombay and in many cities around the world is parkour. And parkour is an urban sort of adventure sport. It's becoming more and more popular it was in fact discussed whether that should be part of the Paris Olympics too. I'm sure will be part of the Olympics in some time. Now, this sport is fraught with danger, fraught with injuries. And this gentleman who's from Bombay is India's best in this, lands up with an injury, has an ACL tear, an MCL tear, and a locked transected pocket handle tear of the lateral meniscus. Now, you can see that that's the locked transected tear of that lateral meniscus. Now, in the past, our only option for these transected tears of the lateral meniscus was to resect them. We had to do a meniscectomy. And we know now that if you do a meniscectomy on the lateral side, a lateral meniscectomy is not going to allow an athlete to get back to his level of sport. So we've got these very fine, small devices for meniscus repair that are now available, which can ensure that you can repair these. And over the last 20 years, the generations have improved and improved. We've also got instruments which are so small and fine, which allow us to suture devices, suture structures with these devices inside the joint. So we can now do meniscus repairs and do some very elegant meniscus repairs in areas that are extremely, extremely small. This is the posterior aspect of the lateral compartment of the knee. And to approach this is so difficult. But if you can repair this, you will get healing, as we can see in this patient, when we've done a reluxoscopy after 4 months for his ACL. So we did the MCL repair and his lateral meniscus repair primarily, allowed that to heal, and then did his ACL reconstruction 3 months later. And then when you go down 3 months later, you can see that that meniscus has completely healed. Now, if you don't have a good device that can achieve this, it's going to be difficult to achieve meniscus repair. And if you don't achieve meniscus repair, in all probability, this athlete's career is over. So I think that he's back to his sports, he's back to what he loves, primarily because of technological advances in surgery that have allowed us to do all of these very elegant surgeries. And when I asked him a few months after his surgery, how are you doing? This is the video that he sent me. This is, I think, about 7 months following the surgery. He was off to some training in Germany and said, okay, I'll show you how I'm doing. And he's back to all of his stunts. And although he gives me a thumbs up at the end of it, I'm almost certain that if he continues these antics, he will be back for something or the other very soon. Our next strategy orthobiologics and regenerative medicine. Again, we know that as surgeons, we are good at structural restoration. So something breaks, we can put it together. A bone breaks, we can put plates and screws. A ligament breaks, we can reconstruct it. A muscle tendon breaks, we can suture it. A meniscus tears, we can suture it. But ultimately, the body does its healing on its own. And we know that certain areas which are devoid of blood supply don't have great healing. Certain areas are not, which are notorious for poor healing rates. And orthobiologics and regenerative medicine helps us in these. So take, for example, this meniscus tear in a fast bowler. So he's an international level elite fast bowler for India. This is his lateral meniscus. There's a locked flap tear in the meniscus, and this is protruding into the popliteal zone. Now, of course, we take that flipped flap out from the lateral meniscus, but you've still got a horizontal cleavage tear, and you've got it in this popliteal zone, which has really no blood supply. And this, being devoid of blood supply, is not likely to heal. If it doesn't heal, it will extend. But over time, this meniscus is just going to become worse. So with newer devices like this very special meniscus repair device that we call the NovoStitch Pro, we can get into this very tight compartment and we can suture it. But technological advances will allow us to suture it. The question is it really going to heal? This place has no blood supply. This region is notorious for not healing. So in these circumstances, we use devices and we use different sort of techniques to help with healing. So orthobiologics and regenerative medicine approaches this topic. So what we're using here is an exogenous fibrin clot. So from the patient's own blood, we take some of his blood, we extract and prepare a fibrin clot. That fibrin clot is then inserted into that area where we want healing. And we know that these fibrin clots will help in the healing process. And then you do your repair over and above this. So you've done your repair, but you're not depending just on the sutures. You're going to depend on the fibrin clot to help with the true healing process, because ultimately these sutures will break. And when they do, if it hasn't healed, he's going to be back to square one. You can see that that's the MRI. We haven't done any reluxoscopy. Of course, he's an elite level athlete who's a cricketer, and we're not going to do that. But we've got reproducible 3 Tesla MRIs, which can show us now that that's a fairly well-healed lateral meniscus popliteal zone. And for the last many years, he's back to cricket again. We also have substances like PRP or platelet-rich plasma. And I think that this again is useful. And it's useful especially for degenerative conditions or muscle tendon tears or chronic tendinosis or areas which have deficient healing. Some studies seem to suggest that PRP may be the way to go. What about our advances in rehabilitation? Because I think, as we saw in that previous lecture, unless you've got really good rehab, as surgeons, we could structurally restore something that's broken or torn. We can help with orthobiologics and get a nice physiology and structure there. But unless our rehabilitation techniques are good enough, you're not going to be able to get this athlete back to his range, his strength, and all the rest. And so in 2021, when Neeraj Chopra, posted this on his Facebook or Twitter, where he'd undergone surgery on the right elbow, an elbow arthroscopy on his throwing elbow, and then won gold a few years later, everyone, lauded the fact that he could do that. But I think no one really realized the amount of rehab that went into this post his elbow arthroscopic surgery. So although the surgery that I did was relatively straightforward, if we didn't have the appropriate rehab, there was no way that Neeraj was ever going to get back to his throwing, skills and to get back to the level that we wanted and get back really in short time, because he didn't have too much time to qualify. His qualification, was he had a last chance to qualify in 2020, and that time was short. And so it was really rehab that ensured that, in a short amount of time, he could achieve his skills of throwing and could then achieve this very historic throw that got him the gold medal and which got India its first athletics gold medal. So I think the real credit needs to go to rehab and the rehab team following his surgery that managed to achieve this historic, legendary moment for India. Finally, what about our understanding of biomechanics? Because if we don't apply sports biomechanics and we don't have better understanding of each sport, because each sport is so different. Each sport is different, the biomechanics are different. And if we don't understand this, then I think that we are not going to be able to do a great job. And so exactly that, in this particular fast bowler, you can see that he has an ACL tear and he's also got a lateral meniscus root tear. And he's a top-level fast bowler. And of course, you will do an ACL reconstruction and you will repair his lateral meniscus root. But if you don't understand the complexities of fast bowling and you don't understand, this is his left knee that goes into hyperextension of almost 15 to 20 degrees. Now, without this understanding of what those biomechanical demands of fast bowling are, we would never be able to get back that hyperextension. And if we don't get back that hyperextension in that left knee, you can see that landing there. In that landing, he goes into almost 20 degrees of hyperextension. And with a standard ACL reconstruction, our fear is that if we don't get back full extension, he's not going to be able to do his ball release, because ball release depends largely on landing leg knee extension angles. So understanding the biomechanics is so critical. And these biomechanics are different in bowling, they're different in javelin, they're different in badminton. So I think understanding biomechanics, understanding sports science is so critical in then ensuring that an athlete that you have diagnosed and then treated and then operated and then done his rehab and then done his biomechanics, this is probably our best sort of strategy to ensure that they ultimately get back to performance. Now, in 2022, we analyzed all of our cases in elite athletes. And by elite athletes, we put them down as anyone who had represented India at any stage. It could be a junior stage, an under-19 cricketer, a top-level cricketer. If he represented India in a sport, then we called him an elite athlete. And we assessed our elite athletes from 2015 to 2021 that we had operated upon. And we had 246 of these elite athletes, and these were the different joints that we had. And we found that we could return 96% of them to sports. Sorry. So we could return 96% of these 246 elite athletes to sports, but we could only return 88% of them to performance. So the difference between performance and return to sports, RTS is return to sports, RTP is return to performance. If you return to a sport, but you're not at the same level that you were prior to your injury, that means, you'd won something, a world championship, and you didn't get back to world championship levels, then you will return to sport. Whereas if you return to the same level as before, or you did better, so someone like Neeraj Chopra, who had never won a gold medal in his Olympics, but then could get back to winning a gold medal at Olympics, we call them return to performance. So we found that although we could get 96% of our elite athletes to return to sports, we could only get 88% of our elite athletes back to return to performance. That means out of the 10 guys that we treated, one guy could not get back to his same levels of performance. And so we analyzed what were the sort of things where we were really lacking and where can we improve. And unless we audit this, we will never really progress in life. And we found that our major problems were with very, very severe sort of injuries. So say this girl had already undergone an ACL reconstruction. She then had a knee dislocation, which then had fracture dislocation of the knee. So when you land up with a fracture dislocation of the knee, sometimes your athlete is not going to get back full range, is not going to get back full strength, and is not going to get back that full confidence to get back to combat athlete, sport like wrestling. So sometimes there were structural issues or rehab issues, and sometimes there were just confidence issues that didn't allow them to get back to sports. The second, and I think the major problem for us, is degenerative conditions. And this is a roadblock. This is something where we really need to improve. And I hope that orthobiologics and regenerative medicine will allow us that. Take, for example, this very young wrestler. He's 27 years old. He's from Maharashtra. And you can see that he's got degenerative joint disease. And that degenerative joint disease, this looks like an 80-year-old's shoulder, large osteophytes, complete deformity of the glenoid and of the humeral head. It looks like a shoulder replacement situation at 27 years. This is not something that we could get him back to elite level sports again. Or like this 31-year-old male football player who's already got degenerative joint disease in his lateral compartment, significant loss of cartilage, significant bone edema there. This is career ending for him because no matter what you do, you can't get him back to that same level of performance. So I think these two aspects, very severe trauma and degenerative joint conditions which cause osteoarthritis, are the two major challenges that don't allow us athletes to get back to sports. But for the others, I think sports medicine as a whole, sports orthopedics has allowed us to ensure that many of the top level elite athletes and the champions that we treat get back to their winning ways and get back to their world winning ways. And I think we have to be thankful to all of the strategies that our diagnosticians, our physiotherapists, our biokinetists, our surgeons, our sports physicians employ to make sure that India's still there in the world level and is beating the top competition all around the world. Thank you.
Thanks a lot, sir. Dinshaw, sir. I think we should take one or two questions. Anybody from the audience, students, delegates, Professor Lingayat sir, Professor Shewari sir. I will have one question, sir. How much percentage of sports persons you have seen or you have treated or just consulted are back to sports at professional level? What should be the percentage?
So, we haven't actually analyzed that, but a lot of the non-operative patients, so patients that we feel don't require surgery, typically will get back. So our elite athletes, our professional athletes who've got sprains, muscle injuries that we treat non-operatively, relatively minor problems, almost all of them will get back. It's very rare that someone like that would not.
Okay.
Our concerns are typically the major injuries, as we just saw. Return to sports happens in our series at least, with a large number, over almost 250 of them. 88% can return back to sport. More than 95% can return back to sports, but only about 88 return back to performance.
Okay.
And I think that's the thing, that we need to try and identify where are the areas where we can improve. And I think these are the two areas. One is degenerative joint conditions, especially for our older athletes. We need to have techniques and ways in which to ensure that we can, make sure that their lives in professional sports are longer. Typically, many of these conditions will be career-ending for these athletes. And if we can ensure good strength and conditioning, a good sort of program, preventive program during their playing years, I'm sure that we can extend their years of playing for many additional years. So I think that's one strategy. Also for our very severe injuries, understanding them better. Someone just mentioned Rishabh Pant. That's a very, very major injury, multiple ligaments torn, extensor apparatus torn, meniscus having, both root tears anteriorly, posteriorly. So these are very severe injuries. And a few years back, before we understood these injuries a little better, I'm sure that this would have been career ending. But in today's day and age, when we understand these injuries better, we understand the anatomy a little better, we have surgical techniques to repair it back and restore anatomy, and then go through rehab and then go through the whole biomechanics, I think then we can achieve our aims and let these athletes live their dreams and fulfill their destinies.
Well said, sir. Any more questions?
Sir, Dr. Shevale sir, he is head of the department of orthopedics at MGM Institute where we are doing the conference. He wants to ask one question.
Dincho sir, very nice lecture, very light. You are the best in Indian contest. The question for you, ACL repair, what is the sequence? Means after how many days you repair the ACL injury? And the sequence of ligaments in multiple traumas, ligaments injury, how MCL, ACL, PCL, and how about your meniscus injury? You tackle at the same time or you a sequential procedure? Thank you.
I'll take both those questions separately. The first one is on timing for ACL injuries. Now, ACL injuries has undergone a sort of a shift where today ACL injuries, the treatment is not just ACL reconstruction. It's a la carte approach. And we know that some ACL tears can also heal. So if it's an avulsion from the femur, what's called as a type 1 Sherman avulsion or a type 2, these avulsions can heal. And so typically we'd like to do a repair. We put a suture anchor and we repair the ACL. Now these ACL repairs need to be done early. So typically they are done within the first 3 weeks of an injury. But if you've got a shattered ACL, a type 3 in the middle, these will never heal. And so these need to undergo reconstruction. And when you're doing a reconstruction in an athlete, you want to do that reconstruction as soon as possible, because the earlier you do it, the less muscle loss and disuse atrophy he has in his quadriceps and thigh. But at the same time, you don't want to do it so early when the knee is inflamed, because you could risk arthropibrosis. So once you have an injury, you've identified that's an ACL tear, we'll start off with icing, rest, prehab, and allow that acute inflammatory episode to subside. This will typically take anywhere from 10 days to 3 weeks. And then once that knee is quiet, it's no longer an inflamed, painful, swollen knee, we'll go ahead with the ACL reconstruction. We tend to be a little aggressive, especially if they've got a locked bucket handle tear of the meniscus or an osteochondral injury that requires to be treated. And most of the times we try and treat everything together in one shot. And if we treat everything together, yes, it's a big surgery, but most of these elite athletes will have good rehab facilities. And so we will tend to do everything in one shot and then go with rehab and therefore save time. In a normal person with the same injury, we would probably not have the same rehab facilities available, and so we'll stage it. If a patient has ACL, MCL, blocked bucket handle, we might do the blocked bucket handle and the MCL first stage, and then the ACL at a second stage, so that we don't land up with arthropibrosis and then lose everything. The second question, what's the sequence of ligament reconstructions in a multiple ligament injured knee? I think that's a great question, because your sequence really will determine your surgical outcomes. So if you have a knee that has an ACL, PCL, MCL, and a posterolateral corner that's torn, typically this happens with a knee dislocation, my sequence of events is that first you need to get that knee in its position. So the PCL, which is the central strut, is the first ligament there. So the PCL will get your position of the knee. Following that, I typically will do my PLC or my posterolateral corner, because the PLC causes a posterolateral rotatory instability of the knee. So you've got your PCL, which gives you your translation and your centering of the knee. The PLC gives you your rotational stability. So your PLC will be second. Your ACL would be third, and your MCL would be fourth. Now, some surgeons prefer to do ACL, then PCL, then PLC, and then MCL. But my argument to that is that if you do your PCL first and then you do your ACL, without fixing your PLC, you land up with a fixed external rotation deformity as soon as you tighten that ACL. So therefore, it's PCL, posterolateral corner, then the ACL, and then the medial sided complex or the MCL. If you've got a meniscus with it, the meniscus needs to be done at the same time. So typically everything done in the one stage and good rehab. If you don't do that rehab well, going to risk arthrofibrosis. So then you choose your patient correctly. If it's not an elite athlete, please don't try and do it in one stage. Do it in multiple stages, much safer.
Right, sir. One question from Dr. Professor Lingayat, sir.
So good afternoon. My question is, sir, what is there is a dilemma between the using peroneal tendon and the hamstring in reconstruction of the ACL? Can you highlights on this? Whether you use peroneal tendon or a hamstring?
Yeah. So, the graft choices for an ACL are multiple. And the standard choices that are available are semitendinosis in the hamstrings from the same side, that means ipsilateral, a bone patellar tendon bone or a quadriceps tendon, again ipsilateral, a peroneal tendon, a peroneus longus tendon has become popular in the last few years, especially for the multiple ligaments, and allografts. So it depends on what you have and what your expertise is for. I typically am not a great fan of the peroneal, tendons, primarily because I suspect that especially if it's a high-level athlete and you take the peroneus longus out, you will land up with subsequent problems of the ankle and foot, both from stabilization and from, the biomechanics. So I typically don't use that. But if you don't have an option, you don't have allografts, it's a multiple ligament knee, you've already taken the BTB, you've already taken the hamstring, the opposite side is something that you don't want to touch, I suspect you could use the peroneal, tendons, but you need to choose that carefully. Choose the patient correctly, and if you choose that patient correctly, I think you'd be okay with it.
Yes, sir. Thank you. If there is no other question, I will like to update about myself. Is it allowed, sir?
Yes, certainly.
Yeah. I got operated by Dr. Dinshaw for my PLC, that is called posterolateral corner, PCL, that is posterior cruciate ligament, and ACL was, I think, partial tear. I don't remember. I am the patient. So he operated me in the first setting as PLC reconstruction, fibular collateral ligament repair, and PCL augmentation. And today I am proud to update to you. This happened in 2012. Right, sir? I'm correct?
That's right.
Yeah. So now, after 12 years, I will like to update you all. This is a proud moment for me. Sir, for your information, simultaneously we are playing matches of all doctors who are IMA members coming all over the country. There is national sports happening by IMA at CHHATRAPATI SAMBHAJINAGAR. I am the event in charge of table tennis. And just now I came back. I won quarterfinals against a Mumbai player, sir. Thanks a lot. So that is the live example standing in front of you all, how a sports person can be back to sports with a good surgeon, good surgery, and a good rehab. That's why I wanted to point it out, sir.
Well done, Akshay. Congratulations.
Thank you, sir. Sir, one last comment by Dr. Shivade, sir.
Sir, your patient is excellent, but he is excellent orthopedic surgeon and endoscopic surgery, doing excellent work, and we are proud of Akshay, and you made everything possible for us. Thank you.
Thank you. And we're, as in the arthroscopic community too, we're very, very proud and privileged to have, Akshay helping many of our, patients all across. I know that many of the patients that come in here often go back and get their surgeries done from Akshay. And I think that that's important to ensure that, the teaching and facilities and surgical techniques are available all across the country. I think it's very important that we disseminate knowledge, that we disseminate, techniques, we disseminate our experiences so that our patients can do better. And, athletes are going to be coming out typically in today's day and age in India, not from the large cities. They're coming out from smaller areas. They're coming out from rural areas, from tier 2, tier 3 cities. It's important that the facilities that we have for them in these areas are world-class and top-notch. And only then can India, finally achieve its dream of becoming a sporting superpower.
Very well said, sir.
I think Akshay is really helping us in that, and many other surgeons are all across the country. and I think many physiotherapists and primary sports care doctors also are. And I think that this is really the way forward for Indian sports.
Very well said. So that's why we are disseminating the knowledge given by you at such periphery levels, because we try to optimize the things available here, because we don't have allografts available, we don't have fresh orthobiologics available. So whatever possible at the such grassroots level, we try to do it, sir. This is just dissemination of knowledge given by you, sir.
Fabulous. Thank you.
Thanks a lot, sir. Thank you from the hall. I will. That's the loud applause for you, sir. You will be able to listen.
Thank you. Thank you.
He is a very busy surgeon, and on this working day, he has given 45 minutes for us. It's a very, very creditable job. Thanks to Dr. Dinshaw, sir, once again. Thank you. Thank you all.
Thank you.
Thank you, sir. See you at PKC, sir.
Thank you.
Thank you, sir. PKC is a Pune knee course happening at Pune, organized by orthoscopic surgeons, Dr. Sachin Tapasvi, Dr. Parag Sancheti, Dr. Dinshaw Pardiwala, and many international faculties come and teach us who are doing orthoscopies to update their knowledge, because this medicine or surgery or whatever is the ever-evolving science, so we should get updated and we should stay updated always, because orthobiologics, there is a workshop on orthobiologics at the I think tomorrow I am going to teach you about orthobiologics. So these are the conservative things for sports persons which make them back to sports. So quickly running for next talk. एक 2 मिनिटात फोन करतो 2 मिनिटात. हां कॉन्फरन्स मध्ये आहे मी सगळ्यांसमोर आहे मी. I'm the coordinator. वाघ सरांना करतो. Simultaneously matches are happening. I'm table tennis coordinator. Somebody wants a bye, he calls me. My opponent has not come, sir मला बाय द्या. आणि मी त्यांना म्हणतो बाय देणार नाही, त्या opponentनी मला फोन केला पाहिजे की मी येऊ शकत नाही. So that should happen in sports, because public are coming from all over the country. Meanwhile, I will like to welcome here Dr. Jagannath Dikshit sir. He is observer from Maharashtra Medical Council for this conference. He is a renowned diabetologist, and almost all of you must have heard about Dikshit's lifestyle. So he is the person. So whenever you want what lifestyle, what food, what should be diabetic diet, what should be the diet for obesity, you are free to ask, because he has already. Pimprikar sir is there. Sir join झाले का? लिंक ओपन होत नाही. 1 सेकंड मी यांना फोन देतो. त्यांना ऑडिओ व्हिज्युअल वाल्यांना देतोय. परत एकदा ट्राय करा. मी पाठवली तीच आहे का बघा. So our next talk is by Dr. Milind Pimprikar sir. He is another sports surgeon from Nashik. He was supposed to be here physically, but for some unforeseen circumstances he is not able to join. He will teach us about काय सर टॉपिक त्यांचा? हां त्यांना वेळ असेल तर मी सरांचं घेऊन घेतो. Biomechanics of running. So what should be a runner should prepare to start running, because there are so many marathon runners, there are so many walkathon people. Many of you also will be interested to join some marathon at some point of life. So what should be the preparation and what are the biomechanics? Means it is a theoretical subject, but झाले सर तुम्ही join? आवाज येतोय. So shortly we will be live with him. I think this is a subject regarding to physiotherapy more. We have hall in charge from Physiotherapy Institute, Sanskruti madam here. We welcome her. सर माझा आवाज येतोय का? अक्षय बोलतोय. Audio is not working, I think. Sir, आवाज येतोय?
I am not able to.
Sir, audio video दिसतोय काही?
Akshay,
yeah,
are you
yeah.
able to hear me?
Yeah, I am able to hear you, sir.
Okay.
You are able to hear me, na, sir?
Yeah, yeah.
So we'll
Loud
start.
and-
So we are running short of time. 20 minutes okay for you?
Yeah, it's more than enough actually.
Okay. So it is biomechanics of running. I have introduced you already. So you can directly start the talk, sir. Thank you.
Right. Thank you, Akshay. So good afternoon. Thank you, Akshay, for this opportunity. First of all, my apologies for not being there physically because of some unforeseen circumstances which arrived here. So today my talk is on running biomechanics, or what are the basics of running. Actually, we know that running is a natural instinct of any human being, and one doesn't have to really learn running because it comes to us by virtue of our own mammalian species. Although, if one needs to excel into this kind of a sport, it is again a question whether you consider endurance running as a sport or not. But nonetheless, biomechanics remains one of the key features. And if one can have some inputs regarding the biomechanics, I think the running becomes much more efficient and much more effective. So what is biomechanics? Biomechanics is the science of a living body, which includes muscles, bones, tendons, and ligaments, which work in tandem to give the effective result. It is essential part of kinesiology, which is a science which focuses upon the mechanics of the movement. So we normally encounter a lot of concepts of mechanics into this. This was a great man, Ben Kibler, who introduced a concept of what is called as kinetic chain. As we know that no movement occurs in isolation. It is always a sequence of movements occurring in the entire body to achieve a fruitful sporting movement. If one can really see here, before we think of performing any kind of fruitful activity, it has been researched and shown that the first thing which happens is the transversus abdominis contracts. So even if you want to pick up a glass of water, before the hand moves, the abdominal muscles, they start contracting. And that is what we call as core, and core stability becomes an essential part of sports, sporting science, and avoiding sporting injuries as well. Thus, to understand the pathomechanics of the injury causation, to prevent these injuries and managing them, including rehabilitation, it is mandatory for us to understand the concept of kinetic chain, which I have already explained to you.
Hello, sir. Can you make it a slideshow? It is
It is a slideshow. It is not a slideshow?
no, sir. It is not slideshow.
Okay. Let me just
bottom. Yes. Yes.
So is this a slideshow now?
Yeah, sir.
Okay, so I was on a presenter's view. Huh?
Yeah. Okay.
No worries. So we have gone up to slide number 3. So that is definition of the biomechanics, which we have spoken about. That is about the Ben Kibler, which we have. Now you can see the slides. Can you see the slides now?
Yes, sir. Yes.
Okay. So lower limb biomechanics is very important to understand if we have to understand what running biomechanics is all about. So to run in an efficient way will improve any sporting performance we know. And we also know that every sport which is played outdoors involves running in some or other form, which could be interval running, intermittent sprinting, which could be endurance running, long distance running, so on and so forth. So if you want to understand running, let's go to the running biomechanics. You can see an athlete running here. And if you see this athlete running, you'll find that he has a certain way how he runs. And if we have to understand this, we have to understand certain principles when you run, which is called as running biomechanics. So whenever we run, there are phases of running. For example, front foot strike, foot inclination, and foot inclination at the initial contact, the angle of the tibia at which the foot strikes, the knee flexion during the stance phase of running, hip extension during the late stance. You have to forward lean, that is a trunk lean, what is your cadence, that is, what is your stride length, whether you are overstriding or short step run. And we also look at the vertical displacement of the center of the mass. So the pelvis has to move if one has to run in a superior and inferior direction. And all these parameters can be studied, all these parameters can be calculated, and according to this, the most efficient way of running can be calculated. Now, if you see this athlete running in a slow motion here, you will see that there is one girl running away from us and a boy is running towards us. You'll see how the foot is striking, at what angle the leg is getting impacted onto the ground, what is the knee flexion angle, what is the trunk lean, and how the center of mass is moving in upward and downward direction. All these parameters can be calculated on a treadmill when you have two cameras of 100 frames per second, which are placed at right angles to each other. And if you place them at right angles to each other, you'll be able to, with the help of sensors, which you can see here, these sensors are put onto the bony prominences and videos are recorded in both the planes to analyze these movements. This is a science which has been proven, and this is the way how an endurance athlete should run. So this is what is called as front foot strike. There are different types. Few people, they strike the midfoot, few people run on the toes, and few have a heel strike as a first step or first mode of running. The heel strike is absolutely no-no, because these heel strike people or endurance runners might sustain the stress fractures to a greater extent rather than the midfoot runners. So for endurance running, midfoot is considered to be a better way of running, whereas for the sprinters, the toe strike is supposed to be a better way of running. And that is why in sprinters, you get spikes which are of negative heel. The heel is not there, and there are no spikes onto the forefoot. This is the foot inclination angle of the contact. So at what foot inclination the foot touches the ground while the first step has got implication onto the injury causation and on effectivity of running. This is the tibia angle at loading response. So when there is a toe off of the first leg, that time this tibia needs to be absolutely in a right position to reduce the impacts. The knee flexion during the stance is most important, because if you see, if this is lesser than 40 degrees, this is 40 degrees. If this is lesser than 40 degrees, then there are increased chances of what is called as patellofemoral syndrome, or you get anterior knee pain, as well as the stress fractures into the second metatarsal neck, the stress fractures into the tibia, what we commonly call as shin splints, or the posteromedial periostitis. The chances are increased in those patients. The hip extension, this is again a very, very important thing, because if the hip does not extend while running, there will be compensation, and this compensation will happen at the lower back. So there is increased spinal extension to compensate for this hip extension. So if you don't have good hip extension, then probably you might land up with low back issues. You can bound. Now, what is bounding? Bounding is excessive displacement of the center of the mass. So to compensate for the loss of hip extension, the athlete bounds, and then that gives rise to further problems. And athlete also compensates by increasing the cadence. This is a trunk lean. Now, if you see here, the trunk is absolutely straight. So the trunk lean should be forwards towards the side of the propagation. So if you have a decreased trunk lean, then there are problems, and one can have more loads or excessive loads over the knees, giving rise to knee injuries or stress fractures at the upper end of the tibia. Overstriding is another issue. So this increased stride length, it has been implicated with increased risk of tibial stress fractures in the runners. So you have to see to it that the athlete is not overstriding, and the foot or the stride length should be identical with the shoulder, of the same side of the shoulder. This is overstriding. This is the shoulder. This is the right stride length to be taken when you are doing an endurance run. This is the vertical displacement of the center of the mass, which I was talking to you. And this center of the mass can be, this displacement can be reduced by increasing the cadence, and which will reduce the vertical displacement of the pelvis, thus reducing the stresses and the efficiency required to run. So when we know that these are the factors which are required for an efficient runner, we need to understand our athlete by doing certain biomechanical analysis into the office or into the consulting when the athlete comes to you. So what do we really see in these athletes? So we have certain frontal plane observations, which are a plumb line which is drawn from the center of the manubrium sternum to the ground. Then you have to consider the level of the shoulders, the ASIS and PSIS, whether they are at the same level or there is an anterior or posterior pelvic tilt. Pelvic tilt will tell you about the quadriceps tightness. It will also tell you about a backward tilt, will tell you about the hamstring tightness. You have to see for the level of the patelli, varus and valgus at the knees, squinting of the patella, and levels of the lateral malleoli. Once you see all these aspects, one can definitely recreate or one can definitely have a prescription given to avoid the mistakes which are normally carried out while doing an endurance run. When you go into the sagittal plane, you have to look for the lateral plumb line, the head position, whether it is in front or back, whether shoulders are protracted or retracted, which happens in swimmers that you have a lot of protraction of the shoulder. They may have an internal rotation deficit. You have to see for the normal spinal curvatures, again, anterior superior iliac spine and posterior superior iliac spine and hyperextension of the knees. These analyses are required to understand the probability, and these would probably dictate us towards correcting these parameters by working on them into the physiotherapy departments. One can also do a functional assessment while observing when an athlete gets up from a chair to see motion of the hip, knee, and the ankle. And this gives us a fair idea about whether the weight distribution is equal, is there any avoidance of any movement which is painful, and the most importantly, what we get to see is in a single leg stance. So single leg stance is one of the better biomechanical assessments which is carried out, where the patient is asked to stand on preference any one of his or her leg according to the preference. And we also watch for the breathing pattern. When there is a single leg stance and the patient is trying to hold the breath while maintaining the stance, that indicates that the patient has got a poor intrinsic core muscles, and you have to work on the core. Trying to hold on the ground by gripping with the toes, like the patient gluteus maximus is the major extensor, and it is absolutely an essential muscle to have a person stand, run, and walk. Sternberg sign will tell you about the abductor weakness, where the glute medius and minimus needs to be worked upon. This test is considered negative if the athlete is able to stand on a single leg stance with eyes closed, maintaining the balance for a minimum 20 seconds, and with eyes open in 40 seconds. So this is one single test which will tell us a lot about the biomechanics of the lower limbs and biomechanics of running. Single leg squat is a further advanced test. Here you see, you have to consider the pelvic tilt. You are going to see for the valgus angulation here. This is the right way and this is the right muscular strength. If there is a valgus collapse, this talks about abnormal biomechanics, and these patients, if they undergo any kind of surgery or like ACL reconstruction, would be more prone candidates for retears of the grafts. Internal tibial torsion and foot pronation are also to be when you do a single leg squat. We also assess the patient on the basis of range of motion, where we do active range of motion and passive range of motion, where we analyze the range, quality of movement, and what is the end point of the movement. So these are certain endpoints which we see, and that we have got to see for all the joints in the lower limbs. We also do a registered isometric testing for each and every muscle, and it is graded according to the Medical Research Council or MRC scale on grade 0 to grade 5, and we compare both the sides if we find that there is something abnormal happening there. It's fine. We put these patients onto different types of strengthening exercises, where we can use these of therabands, can help you equalize the strength of the muscles on both the sides. This is one of the better exercises, which is a prone plank. It is done on an unstable surface. This is our setup where we do this set of exercises and train athletes here for endurance sports as well as for the sprints. This is a bilateral calf raise, very essential for the lower limb. strengthening, and this is done on an unstable. This is a more advanced kind of training in the athletes who want to participate in a greater sport. That's a bilateral calf raise on a stepper. This also starts as a rehab for any lower limb injuries after endurance running or even after sprinting. At any age, this is a cardio come resistive exercise one can do, which is called as battle rope, to get the patients back onto shape. Neuromuscular training nowadays is very much talked about, and this neuromuscular training also helps these patients to maintain balance, coordination, proprioception, and there are various tasks which are given to begin with two legs onto a stable surface and then moving towards the unstable surface and then performing throw ball like trampoline like movements to have the coordination going. Then we come to the strength training for these athletes, where these are called as plyometrics, and this is a strength training which is associated with the agility exercises. These are some tire functional workouts, again give a training and further growth. Running drills and cariokas are important to understand the biomechanics of running and giving different directions with the ladder drills kind of examinations. This is the highest level of plyometrics, where the athlete performs all kinds of movements and different explosive movements and then a duck waddle walk to maintain the balance and the proprioception. Finally, when the plyometrics are up to its peak, these are different kinds of exercises, tight stepper, the hammer exercise, ropes, the steppers, and the athlete then can go back to running after probably an injury, or it can also aid one's running skills when they are incorporated into a running training. What we need to understand is running is not only running is not only cardiac, or it is not only an aerobic exercise. Running needs to be taken care of with resistance training if you want to improve your timings onto long run or endurance sports, or want to undertake an Ironman competition or have a sprinting going on, because it also needs the explosive strength into the lower limbs. So to conclude, running is a basic instinct, but we need to work on it. It can be improved with biomechanical evaluation to prevent injuries and strengthen conditioning exercises. And it is possible to enhance the performance of a runner by incorporating gym training into running training.
हॅलो, थँक्यू सर. शेवटचं थोडंसं ऐकू नाही आलं, बाकी सगळं छान झालं सर.
अच्छा, पहिले सुरुवातीचं ऐकू नाही आलं का?
नाही, थोडंसं ते लिंकिंग प्रॉब्लेम असेल, टेक्निकल इश्यूज, पण सगळं इट वॉज ऑडिबल नाइसली. So I hope some questions from physiotherapy delegates or any orthopedic delegates. So what I understood is plyometrics is a very important thing for a runner or a sports person to get back as a rehab activity or even a prehab activity, sir, before surgery.
Of course. So if we are talking only about running, then what we need to understand is there is a lot of the literature is divided.
Right.
We need to understand that running and running skills are not the only skills that a runner should have. Correct. But they should also undergo resistance training to strengthen the lower limb muscles to have a maximum efficiency when they run. Correct. So that is one part of it. Second is prehab before any surgery. But then I don't think we are talking about any surgery here.
Yeah.
But this becomes an essential ingredient or recipe for any pre-op, post-op, or prevention of injury protocol as well.
Right, sir. So we have a workshop on prehab and rehab tomorrow. A team of physiotherapists and Dr. Abhishek Shinde is going to take that workshop. So if any discussion happening, you can comment on the live link, sir. So there is one question.
Yeah.
Any comment from, there are two professors sitting here, sir. Dr. Shevade sir, he is HOD of MGM College, and HOD of GMCH, Dr. Professor Maruti Lingayat sir. They have some comments.
More than happy to answer.
Shevale sir.
Congrats Milind sir. Nice lecture on different topic day to day for everybody. You have covered all aspects of different newer techniques and how the training should be going. If your training is not proper, you will end up in other orthopedic conditions. So to prevent that, you have summarized very nicely. And young budding athletes who wants to do running their profession, so must go through this all what you advise. And this center should be developed all over country, because a lot of sports now, this is athletics, one of the topmost running, so it shouldn't give a prioritize, and we should start the centers to strengthen the running habits. Thank you, sir.
Thank you. Thank you very
Sir,
much.
Akshay bolte. On behalf of everybody, I will like to request, can you share your lecture so that I can share with all the physiotherapy students and all orthopedic surgeons here who are in sports. Can you share
So,
the lecture
Akshay,
with me, with PPT?
Yeah, so I'll definitely share that.
Yes.
But we are also coming up with physiotherapy protocols textbook, which
Correct.
will be published very soon.
Correct,
Which will have all videos as well.
Yes, sir.
So I will share this, but there is much more to come. And
Sir.
I think we are also writing a curriculum for MUHS in BSc in Sports and Exercise Medicine.
That's so great.
So
So
there is a
great.
lot coming, and we'll definitely like to share it with you.
Right,
Those who
sir.
are interested can just with you. You can share it with the delegates as well as the respected professors there.
Thanks a lot, sir. Thank you. Thank you very much from CHHATRAPATI Sambhajinagar. We'd like to hear much more next time, direct physically, sir.
Sure, sure, Akshay.
Thanks a
Today
lot.
it
There
was
is a
still
round
not
of
possible.
applause for you. Audible.
Thank you.
Thanks a lot. We'll get back to you, sir. Thank you.
Yes, yes. Bye.
So coming back to the lectures, we have only two talks remaining, and the next talk is our esteemed professor of this institute, Mahatma Gandhi Mission and Research. He is the head of the department, Dr. Rajendra Shevale sir. He is going to speak about ACL ruptures, because it's a very common injury, and anterior cruciate ligament, as all of you know, is the most common injured ligament, and it is the most important thing for your knee joint for its stability. So he is going to speak about ACL ruptures, and the last talk for today will be Dr. Manoj Saswade. He is a famous ophthalmic surgeon. He is right here in the hall. He is going to talk about ocular traumas. So that will be all for today. There is hall in charge. I welcome him, Dr. Sachin Deshmukh from IMA Chhatrapati Sambhajinagar. He is managing committee member. And I will take your leave for my table tennis matches are going on. I will be there, and I will meet tomorrow again with workshops. Over to Dr. Shevale sir.
थोडं मी बोलणार आहे नंतर. मी स्टार्ट करतो बोलायला. On the behalf of MGM Medical College and Orthopedics Department, IMA National Sports being held at Sambhajinagar. It is a great honor and pride for us. This such a big event being organized, and on the top there is a SPORTSCON conference being held. So it is a greater opportunity for us to do all sports activities and plus learning how the sports medicine is going on. So sports medicine is a branch combined with different faculties, different disciplines to get what Dinshaw Pardiwala had said. So you get maximum outcome to get 98% to do all the sports activities. So it is a pride, and we have Dr. Lingayat, Professor GMC here, and Dr. Jagannath Dikshit. He is a well-known personality from our region. So, and I welcome Dr. Saswade sir and our Akshay, who has done a lot of efforts. He is so busy, his work plus he is organizing this event. So, starting. So we'll learn the basics. We have seen advanced, whatever at the international level by the Dinshaw Pardiwala. But we have to learn basics of orthopedics. How's the injuries? हे दुसरं दिलं हा कोणतं हा खालचं फॉरवर्ड स्टार्ट इथूनच आता करू नाही पण हे तर दाबायचं एवढंच आहे ना So my topic is ACL injury, anterior cruciate ligament injury, which is the commonest injury which occurs in a day-to-day life with the sports person and the other frequent falls and bleed. So how's this anatomy? So this is anterior cruciate ligament. So it takes origin from intercondylar eminence and it goes and inserts on the lateral femoral condyle, lateral wall of the lateral femoral. So this is anterior cruciate. Why this is called as cruciates? Like a cruciate sign. They cross each other and that's why it is cruciate. And this is posterior cruciate, short ligament, giving a. So these ligaments, they stabilize your knees in anterior translunar and posterior translunar. This is medial collateral ligament, this is tibia and femur, and this is lateral. What is posterior lateral injury is this, the fibular collateral or lateral collateral ligaments which are injured. So this is what is a torn ACL. You can see the ACL is mid-substance tear is there. So what Dinshaw Pardiwala said, if there is a tear here in the origin or insertion, it can be treated conservatively, that heals if you repair it. But these injuries in the mid-substance, they don't heal. So patient had instability problem, that's why we have to reconstruct this ligament by putting grafts and all. So this is a fan-shaped ligament composed of densely organized collagen fibers. This is specific collagen which gives a lot of strength and attaches a femur to tibia. From femur to tibia, that is how the ACL is formed. What are the attachments? On the femur, the fossa of the posterior medial edge of the lateral femoral condyle. Where it is? This. Sorry. This area. That is PCL. This is posterior. So on the tibia, the fossa anterior and lateral to the tibial condyle. How the fibers of the ligament divided into two bands, the anterior medial and anterior lateral. This is the first is tight in flexion and the second one tight in extension. That is very important. The function, what are the functions of ACL? Anterior, how it functions? A primary function of the ligament is to limit anterior displacement of tibia. It should prevent anterior displacement, and that is the primary function of this ligament, and prevent hyperextension. And that's why if we got hyperextension injury, there is ACL rupture. So it prevents hyperextension, and that's why. Then secondary functions, it restrains tibial rotation and varus and valgus angulation at the full extension. These are the two main functions of the ACL ligament. What is the mechanism of injury? The contact sports, high energy traumatic injuries. You have accidents, collision, contact sports, non-contact sports, changing the direction and rapidity. Suddenly you start running and immediately you stop, and that time your ACL can be torn. stopping while running, landing from the jump incorrectly. If you don't land properly, you get that ACL injuries. This is the figures just showing different types of injury. Athlete, how this is, third one is fall wrong, fall from this leads to injury, and the football player hitting the ball, and the other players, he hits his leg, and there is a hyperextension injury, and that's why you are getting all this. Twisting is a common injury. Twisting, if the femur is rotated and tibia is fixed, you get that injury, hyperextension and twisting. So these are the different injuries. It is divided, grading, how severe injuries. Grade 1, mild injury, grade 2, moderate injury, and grade 3, severe injury. Grade 1, only microscopic tears, which is not seen on the MRI or CT scan, only edematous, do not affect overall ability of knee joints, and these patients requires a good physiotherapy, good rehabilitation, and they recover absolutely normal. The grade 2 injuries, the ACL, particularly knee is unstable and can give periodically difficulty in the standing and walking. There is instability. The partial tears, which is shown here. This is a partial tear. And the full thickness, there is severe injury that ACL is completely torn and knee becomes very unstable here. This is a torn ligament and this is very unstable condition and you require a lot of falls and everything. What are the clinical features? How you will diagnose? What patient will tell? The popping heard by the patient. There is a popping sensation in the knee and patient tells. Pain and swelling because all inflammation and everything sets us. So swelling, edema, hemarthrosis, knee effusions, loss of full range of motions and tenderness. So these are the acute injury. Chronic injuries, they have a discomfort while walking. What are the different tests for how to diagnose anterior drawer test for the anterior cruciate? Patient is kept in supine position. This is you have to fix the pelvis first, and this is the femur and knee is flexed. The examiner is sitting on the foot of the patient to stabilize the tibia. Now his hand is on the posterior part of the fingers, posterior part of the upper tibia, and two fingers over the parallel to the ligament joint line. And then he exerts the pressure anteriorly, pulls the tibia. 45 degrees knee is flexion. Foot is prevented from sliding and the tibia is drawn towards the both ends. Test is positive, tibia moves forward more than uninjured leg. You have to do this test on the normal side. How is that? Some patients have laxity, and that can lead to misdiagnosis. It is not all the time it is. So on the normal side, first the anterior drawer test is done, and then on the affected side. This is one of the very good tests for clinical diagnosis. Clinical diagnosis is very important than going for MRI and all. If your test is good, you are satisfied that this ligament injured, this Latchman test is best. Better sensitive than anterior drawer. There are fallacies of anterior drawer test. So that's why Latchman test is done. And it is clinically significant. One can say that ACL is torn. Patient in meds, this is the position how the knee is flexed 20 to 30 degrees and tibia is pushed forward on the femur. Then what are the investigations? Now the MRI is the goal. First, I think X-ray should be done to rule out any fractures, tibial spine, intra-articular fractures, and then X-ray of the knee joint, API and lateral oblique waves. MRI is the gold standard. Plain X-rays that is to rule out the avulsion fractures, and arthroscopy nowadays is the best investigation. What are the treatment modalities? You can do a conservative treatment. All ligaments need not. One of my ENT friend is there. He's got ACL tear last 25 years. He is fully active, he is doing all work, but he didn't get operated. So it is not necessary all ACL should be done. In an elderly group, when osteoarthritis knees settle, the patient activity is limited, one should not go for this repair of this. In a young athlete, active person, when he is finding the difficulty in stabilizing, these are the patients where surgical indications are important. That's why role of conservative treatment, all physiotherapists and team is very important. One good physiotherapy for a long period of time can recover almost 75%. So he can do all his activities, and that's why role of rehabilitation is most important. So what are the conservative treatments? What are the indications? Partial tear, isolated tears of ACL, no instability symptoms. Patient do light manual work to live a sedentary lifestyle. Children and young adults, risk of growth plate injuries very high. That's why we don't do a repair surgery here. What are the methods? You got different braces. Aggressive rehabilitation program is counsel about the activity level. After swelling decreases, physio and muscle strengthening exercises. Braces are important to stabilize the knee externally. There's a functional brace treatment, what all physiotherapists are doing, and rehabilitation braces, they are control movement during the rehabilitation process. What are the surgical treatments? The professional for indication for surgery. These are the criteria where to do a surgical intervention. Professional athletes, they are high demand. They want their knees to be stabilized and perfect. Otherwise, they cannot do all these activities. That's why the professional athlete is a priority for ACL reconstruction. Associated meniscus injuries and collateral. If you have meniscus injury, it locks your knee and creates more problem, and collateral ligament should be repaired. Recurrent episodes of giving away and recurrent effusions. These are the one of the common ACL injury symptoms. Persistent anterior pain, one of the indications for surgery, and tibial spine avulsion, that is fracture which is commonly seen and can be treated with the arthroscopic or open surgery. Timing of surgery is very important. Swelling of the knee is inflamed, so we should wait for knee to go down, give anti-inflammatory drugs. Range of motions of the injured knee, good quadriceps muscle strength must be present before surgery. Usually it takes 2 to 3 weeks after injury. Presence of any associated injuries to the knee joint involving collateral ligaments, meniscus, and so it is not all the time you get only ACL tear. You got associated injury, that you have to rule out. Otherwise, you will not get full functional recovery. If the meniscus is torn, what Dinsha has showed, we have to repair, reconstruct, or whatever. What are the surgical reconstruction techniques? So graft fixation, then graft use, autograft, patellar tendon, hamstrings, and quadriceps. Then you got allografts. In the Western countries, they are using allografts from cadaveric specimen, and then they are coming with synthetic grafts for the repair of the fixation. Can be done in 2 types. Anterior fixation with interference screw. You put a graft and fix with the interference screw, or suspensory ligament. The suspensory fixation is there, endo buttons or tightrope. These are the techniques how the graft should be fixed. What are the complications of this ACL? When you get adhesions or arthrofibrosis because of intra-articular adhesions, partial tear, regular ossification in the ligaments, so it called as Pellegrini-Stridda disease. This instability is one of the complications. If ACL is not treated promptly, so you land up in a osteoarthritis. Lot of forces are acting on the cartilage, and you start wear of the cartilage. So osteoarthritis is one of the complications. What are the after surgery? Loss of fixation is one of the complication. Infection is complication. Re-tears of whatever your ligament reconstruction, re-tears are common, and infection should be addressed. So this is a video showing the how the repair is to be done. This is the graft they have put. So we did semi-tendinous graft. Now the graft is in place from tibia to the femur. The shining graft is there. So this is another video how this tunnel is bent and how this graft is pulled inside the joint and fixed to the tibial and the femoral tunnel in a anatomical position. We give different stresses. There is a procedure called as ligamentotization. After putting the graft, you do a flexion and extension. So this is a tendon we are converting into the ligament. So ligament strength is different and tendon strength. So we have to adapt and develop that, convert that tendon into the ligaments. So we have to do a good physiotherapy for that ligamentization of the tendon. So thank you. This is basic lectures. On the behalf, I really thank you for organizers giving me chance to present my work. Thanks.
Thank you, Shivari sir, for this basic and informative presentation on ACL. Audience, any questions? Okay.
Okay, thank you.
Sir, 1 minute. Sir, 1 minute. I request Dr. Lingayat sir to give a token of appreciation to Shivari sir. I request Dr. Dikshit sir also to join. Please give a round of applause. The next and the final presentation of this today is from Dr. Manoj Saswadi sir. He is eminent ophthalmologist and retinal specialist from Aurangabad. Thank you sir for sparing the valuable time from your busy schedule.
Thank you organizers, not only for giving me the opportunity, but for conducting such a national event at Chhatrapati Sambhajinagar. You have done a wonderful job of conducting such a national sports activity in our city. And apart from that, you have coupled it with the academic activity. That is more admirable or appreciable. So today I will be presenting my little bit of the work which we have done in the Aurangabad since last 25 years. Yes, thank you. The ocular trauma is one of the commonest emergency situation, as it is in the orthopedic and other faculties also. And we know that the eye is a very important sense organ. So I won't say, Shivari sir, that you are not important. Your injuries and our injuries has a different aspect of lookout. If eyes are not there, obviously, हम बोलते एक आधी टांग टूकी तो क्या फर्क पड़ता है, दूसरा जुड़ा देंगे. लेकिन आँख फटी तो क्या है, फिर कुछ नहीं, दुनिया कुछ नहीं है. It is like that. So we will see what is the biggest spectrum of the ocular trauma. There are so many types of injuries. Any injuries can be divided into a closed globe injury or open globe injuries. There can be a contusion, lamellar laceration, full thickness laceration, or a rupture of the eyeball. Eyeball, you know that this is actually a layer of the three coats, sclera, choroid and retina, and front layer is a cornea. If there is a full thickness, that means all three layers are been ruptured, while laceration is a partial thickness of the tear. Then these are the contusions, ruptures, and all these mechanisms. We'll go through this various types of slides. This is one of the severe injury which has caused the proptosis of the globe as well as subconjunctival hemorrhages and chemosis. And if we want to see examine these types of patient, then obviously like an orthopedic examination which sir was showing in with the picture, same thing in the ophthalmology. You have to check first the vision, what is the extent of the injury, whether leads are involved, there is a penetrating or perforations, globe contents have been come out, pupillary reaction is there or not, and whether the retina is visible. All those things are very important. Here you can see that these are the ruptures, cornea is tear. Here the lens itself has been ruptured and came into the cortex. Lens, that cataract has come in the anterior chamber, and this is also one of the injury with the lens inside. Then this is another injury where the penetration has been, corneal perforation has occurred, and there you can see that this is a whitish material which is called as a hypopion. That means because of the injury, the septic thing has been occurred. That means infection has been developed into the eyes. These are the open globe injuries, and at the time of the injury, we know that the atmosphere is not a sterile one or a good one, like in the theater. So whatever the atmosphere it has occurred, it will also carry the organism inside and cause the infection. So immediate care of such types of injuries is very important, to take care so that there won't occur the infection, and you may prevent the loss of vision, as well as you can salvage the eyeball, either visually as well as tectonically. Then there are various types of industrial traumas or injuries. Here you can see this needle wire has been gone inside the eyeball, and we have removed it, and you can see that this much long needle was inside the eyeball. Then there are, you can see this contents. This is a choroid and iris ciliary body has been came out with the hyphema. That is, the whole chamber is with the full of the blood. Then these are the major traumas which need to be sutured immediately and maintained. This is one of the case where the blast injuries has been occurred. Nowadays, pataka, when we people in the childhood also, we won't used to fire it simply on the ground. We used to put some material or tumbrel on it and blast it. Same thing has happened. This cup got blasted out and gone into the eyes, and you can see that the the boy has lost his eye, and how much of the big size of the Chinimati cup has gone inside and torn it. Then there are blast injuries in the various types of situations which can cause the inside ruptures also. And these are the bullet injuries or fire injuries. In nowadays, this is very common in India also, as it is very common in US. Same thing, if the bullet passes near from the eyeball, it may go into the brain as well as in the sinuses. But this impact of flying object causes the ocular injury, and patient can lose the vision. Then there are the various types of injuries, blunt traumas, which can cause the dislocation of the intraocular structures. What are the intraocular structures? Is the lens, whether it is a natural lens or artificial lens. They can get rupture and patient becomes immediately blind. Then this is a trauma because of the penetrating injury. You can see that the clear lens has become opaque or white. That is, after repair, you can see that the globe is been salvaged. This is a dislocation of the artificial lens. Patient has already undergone the cataract surgery, and they have put the intraocular lenses, but because of the injuries of various types, they have fallen down and the vitreous cavity. And little bit of blunt traumas of any type can cause the vitreous hemorrhage. That is, so the media becomes opaque. If the media is opaque, the images will not be formed on the retina or on the brain very properly, and patient gets immediate blindness. These are the things because of the blunt trauma. You can see the intraretinal hemorrhage has been occurred, and patient is losing the visions. Certain types of things that because of the injuries in the coral, particularly young people coral, and they hit on the eyes by any material, whatever it is available. This was a patient where they occurred the hemorrhage. We repaired it, and patient since last 15 years is maintaining the good vision. Then these are the quarrels in the household, particularly the husbands when he is drunken and is not getting the more money from the wives. This is very common in socio-economical Jhopadpatti areas. They hit on the eyes of the wife, and you can see this bleeding occur inside the eye. This is the real time stories in Aurangabad itself, and we have drained it with the laser, and patient's vision is immediately repaired, and the further litigations in between the family also is been solved via the ophthalmologist within a few minutes. And these are the blunt traumas where they are ruptured and blocked the arteries and veins. You can see that which can occur in a crush injuries in orthopedic. Same thing happened. You can see this half of the vascular supply has been lost because of the ruptured vessels. Then this blunt trauma can cause the hyphemas, and this is very common and can cause of worry in particularly in children's. Then if it is depending upon the severity of the injury, you see that the retina has been torn, it is called as a giant retinal tear, and this warrants a immediate surgery. And then there are, this is shuttlecock injury. You can see this is a rupture because of the shuttlecock injury, and we have done the laser and repaired it. This is an giant retinal tear because of the trauma. This trauma can be of any extent. Here you can see the whitening and scar is there, and subretinal hemorrhage has been occurred. Subretinal hemorrhage has been occurred means some neurons and ganglions have been lost and patient's vision is little bit compromised. Here this was a doctor's son who was playing shuttlecock at 9 o'clock in the night and suddenly got the injury. You can see this, all this is blanching of the retina has been occurred all over. Patient lost the vision to 1 meter only. We treated it and now he is a 6/6 vision with continuing his job in the IT. Then there are certain injuries because of the ball, cricket ball and all those. You can see the hemorrhage has been come in, iris has been torn and bleeding is inside. These are the very common road traffic accidents. This is a child which was hit by the teacher on the right lateral temporal aspect during the school. The child has been lost his vision because if you hit on the lateral side, the optic nerve which is there in the opposite gets the kink or sudden jerk and loses its contact from the brain, like an mango which is attached to the tree with the stem. That stem, if you hit little bit, it will fall down. Same thing happened. You can see that there is a optic nerve head avulsion has been occurred. You know the avulsion means something is separated or detached from the its natural position, and patient has immediately suddenly got the blind, completely blind forever in the life, throughout life. Same thing occurs when the road traffic accidents. You know that the patient falls directly on the temporal aspect of the things, and there occurs he is most of the times life is saved, but the eye is lost because of the optic atrophy has been developed. That is afferent fibers from the optic nerves have been lost. This is again in the farmers. You know that this goat horn, that is Shing Laglani, the globe has been ruptured. This is very common, bull horn injuries, goat horn injuries, and people lose vision. That is a professional hazard, or we can say that. Then there can occur the retinal detachment, choroidal detachment, and patients get difficulties in the vision. Here also what was a globe rupture which was repaired, but the inside you can see that there were hemorrhages and retinal detachment. On ultrasonography you can see the retina has been detached from its natural position. Then there are certain trauma which can cause the macular hole. This is called as a macular hole. Macula is responsible for the 80 to 90% of the vision, which you can see the color, contrast and all those things because of sharpness is because of macula, and this is almost maximum 3 millimeters area, 300 micron, and if it is ruptured, your vision comes down to 10%, and this is because of trauma. This is another case where the cooker blast injury. The lady was doing cooking and suddenly the steam came inside, and you can see that there were burns on the neck also, on the clavicle also, and the face also, and inside the eye. Because of this forceful injury, the retina got torn. We repaired it, done the surgery, and now she is doing very well. Then there is another case called as a sympathetic injury. You know that if one eye is injured, why the penetrating injury, the eye's pigment epithelial cells gets excited to the antigens, which is already, otherwise it is a closed chamber. It is not exposed to the antigen or lymphatic system of the body. Once it is open, then it is called as the exciting eye. It excites the immunological reactions, and the same reactions goes into the other eye, which is a better eye, normal eye, and that starts developing the detachments and recurrent uveitis, and patient loses the vision. This is again, we can see that there is a exudative retinal detachment in this case because of the lost eye. So in such cases, you have to treat with the severe acute management like IV methylprednisolone, and this way you can save the vision. Now you can see that this was a condition before starting. You can see there was a detachment, and now after the treatment it has been resolved. So these are the things. Then choroidal ruptures are very common because of the trauma. You can see these linear, semi-lunate type of ruptures have been occurred because of the various types of traumas, and patient loses the vision. Then RPE atrophy is sometimes is there because of the blunt trauma and patient vision. This is one of the commonest thing you can see. You will see in that if you are involved into the emergency casualty emergencies, then such types of corals usually happens in the city, and they hit on the eyes with the mustache, with whatever the rings and all those things, and this type of black eye is there, and it is the external one can see that, but inside there can be of injuries of any grade, and patient may suffer severe loss of vision and surgical procedures also, and at times it becomes a very litigations go to any extent, so the doctor should take care that all these MLCs should be preserved. Then this is the optic atrophy because of the injuries. These are the intraocular foreign bodies. If the flying object, if chisel and hammer workers are there, usually the chisel and hammer we see that the stone will go and cut, but this chisel and hammer usually cut the iron particle, and it flies inside and goes inside the rupture, because eye is the most tiniest or delicate organ in the body, and it goes inside, and you can see that there are various types of foreign. This is one foreign body, there also foreign body. This is a metallic foreign body, and which has produced the reaction around it, and this is covered with the capsule, and this is a foreign body inside the lens. These are the local cases. Here also one of the foreign body inside, because of the foreign body, as infection has gone inside and patient has started developing the infection. So this is an sort of emergency. One can do the surgery earliest possible. Here also you can see the foreign body here, flying object gone inside. Bleeding was there, and we have done the surgery to remove that foreign body, and patient has retained the good vision. Then solar retinopathy. Usually you do the solar eclipse without wearing the protection, and that is a very heroic thing for few people. Nothing happens to me. It is a very good. Even welding arc injuries. This is a burn because of welding. I do the welding and nothing happens to me is a very common word, or the heroic things people do, but they don't know that the welding arc injury causes the burn on the retina, and patient loses the vision forever. And this is very radiation retinopathy, particularly when the radiation given on the face or near to the eyeball, maybe in the neck or head, without taking care or protecting the eye, then the radiation can go inside the eye and cause the radiation occlusive vasculopathy and cause the retinal damage. And these are the local cases. This is another farmer. You can see that farmer lightning injury. वीज पडली शेतामध्ये बाजूला, त्याला बर्न झाला, ठीक आहे, but when he came after few days, you can see this blanching has been occurred because of the heat and lightning, and we treated it, and now he is doing very well. Then other road traffic accidents where the chest compression has been occurred, some tire has been gone, scooter has been gone from the abdomen, whole superior vena cava pressure will increase, and where it will go? It will go into the head. The same way, if it ruptures the blood vessels in the brain, same thing, this causes the rupture of the vessels in the eye also and cause the blindness. These various types of. So what is the conclusion is that the injuries is you cannot prevent all the times, but you can protect to some extent wherever you work, in the factories, in the farms, or in the hospitals, or wherever. You should wear the protective goggles. Simple injuries with the chlorine, if you are not wearing the glasses while swimming, the chlorine will cause the epithelial defects and injury, and patient is very horribly painful throughout the day, watering and all those things. Or in ultraviolet rays injuries in the hospital, where the UV rays goes inside like an welding arc and causes the injuries. Same thing in the welding, you can see this welding arc injury. These are very common. Patient typically comes in the midnight with these types of, he has done tolerate some 6, 7, 8 hours with these injuries, but at the end of the day, in 1 o'clock or 2 o'clock in the night, he will come with the shouting that I do something for me. So basic crux is that you should take care by preventing the injuries, and all these are the safety goggles are always available, and you should use it. Thank you very much. Thank you for giving me the opportunity once again, and nice to present in front of Dixit sir and everyone, Shivai sir and Deshmukh sir. Thank you, sir.
Thank you, sir, Saswadi sir, for this interesting presentation. I will request Dr. Shivai sir and Dr. Dixit sir to give the token of appreciation to Dr. Saswadi sir. Sir, one question. Sir, one question. Is there a role of rehabilitation in ocular injuries? role of
rehabilitation. Yeah, rehabilitation is always required with whatever the injuries occur or surgery is done. Particularly here, the good thing is that we are having two eyes. God has given two eyes. If bilateral injuries are there, then the rehabilitation is a different issue that goes into the blindness schools and all those rehabilitation. But if it is a unilateral injury, still the patient is having one eye and he can salvage his rest of the life without any problem. But the rehabilitation is there for the, if he has undergone the surgery, then obviously all the surgical protocol for 2 months has to be followed. And the rule is that in injuries, particularly one surgery is not the rule. Multiple surgery is the rule in ocular injuries. You cannot tackle all things in one sitting. Step-by-step approach is advised.
So take-home message is just avoid the ocular injuries.
It is most of the time why road traffic accidents are common, sports injuries are common, industrial injuries are common, farmers injuries are common, and these are preventable. We go any factory and see where are the safety gadgets. Nowhere is using those gears. Even in the sports also, we know that every sport has given these things, but no one uses these things, and then the injuries and its implications are there. Thank you.
Thank you. Thank you. I declare that today's session is over now. Let's will meet tomorrow. And
दिसलं काही ना की मला तुमची आठवण येते. आता कसं करा मी तुम्हाला भेटलं किंवा कसं होईल असं वाटलं मला की तुम्हाला एमसीएफ ऑफर्ड दॅट तुला मी स्पेशल देतो येतो तुझ्याकडे तू येतो पण काहीतरी कर पण काही झालं नाही माझ्याकडनं चुका होता. काम करणं बरोबर काम चालू आहे इतकं काम आहे ते म्हणलं आता 2-3 केसेस काम एवढं असतं की 2 केसेस आजच्याच सकाळपासून 2 केसेस आला कसं
hello. I'm requesting Dr. Saswati sir and again Dr. Shivai sir to felicitate Dr. Dikshit sir, who is the MMC observer for this conference.
I request Dr. Vikas sir, our organizing secretary and branch secretary, to please come forward for IMA prayer. And I request all the audience to stand in a pledging position and repeat after Vikas sir.
Good evening all. May everybody be happy. May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. May we be the healing cure beyond every greed and lure. Thank you very much. Now, Dr. K.P. Sane, our Vice President, will come for the flag salutation. Please don't repeat after him.
We, the members of Indian Medical Association, stand here to salute our national flag. Its honor and glory shall be our light and strength, and its course shall be our course. We pledge our alliance to it, and realizing our responsibilities as the accredited members of the national organization, we swear we will dedicate everything in our power to see it fly high, the Committee of Nations. Thank you.
Please be seated.
Jai Hind, Jai IMA. Now for further proceedings, I invite Dr. Mrs. Niti Soni ma'am and Dr. Mrs. Roshni Sodhi ma'am. Dr. Niti ma'am is here.
Good evening, one and all dignitaries on the dais. We'll start with the felicitation program. I now invite our dynamic president, Dr. Ujjwala Dahipuri madam, to felicitate our IMA national president, Dr. R.V. Ashokan sir. Request Londe sir and Ingol sir to please come on the dais, please. Now I request our dynamic secretary of CHHATRAPATI SAMBHAJINAGAR, Dr. Vikas Deshmukh, to please felicitate Dr. Sharat Kumar Agrawal, the immediate national IMA past president. I request our Vice President Dr. Kedar Sane sir to felicitate IMA National Vice President Dr. Shiv Kumar Utture sir. Now I call Dr. Praful Jatale, our treasurer, to felicitate Dr. Jayesh Lele sir, who is the National Health Scheme Chairman. Our Vice President Dr. Renu Borarkar will be facilitating Dr. Santosh Kadam, President IMA Maharashtra State. Our Joint Secretary Admin Dr. Archana Sane Madam will be felicitating Dr. Anil Awad Sir, who is the Secretary IMA Maharashtra State. President-elect CSN Dr. Anupam Takarkar will felicitate Dr. Santosh Kulkarni, President-elect IMA Maharashtra State. Joint Clinical Secretary Dr. Akshay Maravar will be felicitating Dr. Praveen Suryavanshi, CEO and Dean MGM Medical College. Building and Plot Committee Chairman Dr. Kuldeep Singh Raul will now be felicitating Dr. Vasant Lunge sir. I request Dr. Sachin Deshmukh, Managing Committee Member, to please come to felicitate Dr. Vasant Lunge sir. Joint Cultural Secretary Dr. Prashant Deshpande. I request Dr. Sachin Fadnis to please come to felicitate Dr. Ravindra Kutte sir, past President IMA Maharashtra State. I request Jhawar Madam to please come to felicitate Dr. Ravindra Kutte sir. I now call Dr. Jilla sir to please felicitate Dr. Santosh Ranjarkar sir, who is Vice President IMA Maharashtra State. I request Musande sir to please come to felicitate the Dean of Government Medical College, Dr. Shivaji Sukre sir. Okay, so I request him to felicitate Dr. Paras Mandlecha sir, who is MOH Municipal Corporation. Now I call Dr. Ishrat Barudwala to please felicitate Dr. Dayanand Moti Paule sir. Please felicitate Dr. Ingole sir. Dr. Ishrat. To please felicitate Dr. Londe sir. Dr. Ishrat to please felicitate Dr. Londe sir. I call Dr. Shinde sir to please come and felicitate Dr. Ingole sir. Now I request Secretary Sir Dr. Vikas Deshmukh to please felicitate Dr. Jagannath Dikshit Sir. He is the MMC Observer for IMA SPORTSCON 2024. I request Dr. Praveen Suryanshi sir to felicitate the dignitaries on dais on behalf of MGM. Dr. Ashokan sir is felicitated by Dr. Praveen sir. Praveen sir to felicitate Dr. Sharad Kumar Agrawal sir. Dr. Praveen sir will now be felicitating Dr. Santosh Kadam sir.
All dignitaries, please be seated. Now I request, please, Pratima ma'am, Sangeeta ma'am, please come forward to felicitate our ambassador, Dr. Kailash Sachdev sir. आइए sir.
Thank you, everyone. Now I call upon our President of Chhatrapati Sambhajinagar, Dr. Ujjwala Daifare, to give the welcome address.
Good evening, everyone. Respected, beloved, visionary leader of IMA headquarters, our President, IMA, Dr. R.V. Ashokan sir, ever inspiring, motivational, very good orator, leader of IMA headquarters, IPP, Dr. Sharad Kumar Agrawal sir. He is the key in getting IMA national sports for our IMA Chhatrapati Sambhajinagar branch. Encyclopedia of IMA, orator of IMA, Maharashtra State, respected Utture sir, who is a Vice National President of headquarters. Respected Lele sir, he is the past Secretary General headquarters, and his continuous follow-up with President and Secretary at national level and guidance time to time regarding these national sports help us a lot. Our own IMA branch member and past secretary, he stands with us for each and every medical issues. He is a MP of Chhatrapati Sambhajinagar, ex-Finance Minister of India, Dr. Bhagwatji Karad. Due to elections, he is not available today. Otherwise, for each and every IMA activities, he is always with us. Dynamic, enthusiastic, very active and social, newly installed IMA Maharashtra State President, Dr. Santosh Kadam sir. Immediate past President Maharashtra, Dr. Kute sir. Our constant support, motivation and encouragement for our branch. Dr. Anil Awad sir, who is newly installed Honorary Secretary Maharashtra State. Newly elected Maharashtra State President, Dr. Santosh Kulkarni sir. Dr. Anil Kumar Naik sir, Honorary Secretary Headquarters. Due to some unavoidable circumstances, he could not attend today's function. He is always helpful and of supportive nature, who is constant support, motivation and encouragement throughout this national sports event. This event is possible only because of his constant support and motivation. MGM's Dean and CEO, Dr. Praveen Suryavanshi sir. He is always a guiding force, and he is the first person, once we got this conference, we went to him. He said, "Do not worry about anything, I am always with you." And sir, because of his support, guidance, we are doing conference in MGM Medical Campus. And he is always very good support for all IMA activities. Our family friend, Dr. Paras Mandlecha sir, who is a MOH, who helps us for all medical issues in Chhatrapati Sambhajinagar. Dr. Jagannath Dikshit sir, who is a MMC observer and who works on weight loss. Respected Londe sir, IPP Maharashtra, IMA Maharashtra. Dr. Vasant Lunge sir, who came on the way from Amravati. He is a joint secretary of CGP National. Okay, headquarter joint secretary. Dr. Sunil Ingole sir, he worked very hard and he given all the opportunity to all the branches when he was a cultural secretary. And he came on the way from Ambejogai. And our brand ambassador, Dr. Kailas Sajdev sir. All members of organizing committee, delegates, players and press reporters. A warm welcome to all of you on behalf of IMA Chhatrapati Sambhajinagar. At the outset, I thank you, IMA Headquarters President, Dr. Ashokan sir, IPP, Dr. Sharad Kumar Agrawal sir, to allow us to conduct national sports event. Our branch has a strength of around 1800 doctors. 6 branches are sub-districts. Then all basic committee working throughout day and night for this national conference. And for IMA CHHATRAPATI SAMBHAJINAGAR, we are working on Aao Gaon Chale project, who is the dream project of our national leader, Dr. Ketan Desai sir. And sir, we are proudly mention here that we are running free OPDs throughout year in IMA premises. Total participants for this national sports are 624, and into that 885 games they are participating. That means almost delegates are 885. This sports, we are parallel along with sports, we are running a conference which is an academic activity, and for that it is a hybrid mode, and we got 6 credit hours for the conference. Every medicos have liking for either sports or music. It's a great and proud that IMA CHHATRAPATI SAMBHAJINAGAR has topper players, state, national and international. All my coordinators working very hard. We are managing all the games and activities of our own without any event management. Thanks to IMA headquarters for constant guidance and support. Here I want to mention our leaders. Immediate past president of IMA CHHATRAPATI SAMBHAJINAGAR, Dr. Yeshwant Gade sir. Vice President Maharashtra, Dr. Santosh Ranjalkar sir. And President-elect IMA CHHATRAPATI SAMBHAJINAGAR, Dr. Anupam Takalkar. They are the constant support and guiding forces for this IMA national sports. National sports event had overwhelming response, more than 885 participants. Our organizing team is working very hard from last 2 to 3 months to make this event most successful, memorable and uneventful. Our brand ambassador, Dr. Kailash Sachdev, definitely motivated members to register for national conference. My office bearers, organizing team, various delegates, faculties, coaches have taken painstaking efforts, compact follow-up to give excellent hospitality. I again cordially welcome all our esteemed guest delegates for National Sports Event and SPORTSCON, which is the first every grand event in Marathwada region. I hope all games, stay, hospitality for these 4 days will be comfortable. If there is any lacuna, feel free to contact organizing team. Friends, another proud moment for every IMA member is our IMA headquarter building. We as a IMA CHHATRAPATI SAMBHAJINAGAR contributing 1 lakh rupees towards the building fund, and definitely our individual members will be donating generously for the IMA headquarter. Hey, Vikas, check do. आणि डॉक्टर राव डॉक्टर थैंक यू ऑल ऑफ यू. जय IMA.
There are a few felicitations left from my side. So now I request Dr. Akshay Maravar to please felicitate Dr. Yashwant Gade sir, who is the immediate past president of Chhatrapati Sambhajinagar. I request Roprekar madam to please come to felicitate Dr. Kuldeep Raul sir, who is the building plot committee chairman. So going ahead with our today's program, Dr. Ashokan sir has a flight to catch, so I'd like to invite Ashokan sir to please come and say a few words. Sir has been a practicing physician based at Punnalur in the Kollam district, and he has conceived and established IMAGE, which was a project to handle the biomedical waste of the entire Kerala, and he is the chairman of the scheme for past 6 years. Over to you, sir. The CV is long, but I am just making it short because you are a very well-known personality, sir. Thank you, sir.
So pardon me if I had left out any name. Mentioning names may look superficial, but peer recognition is so important in medical profession, because medical profession, a doctor doesn't earn anything else. So important for the doctor that what other doctors think about me. The respect that you gain in the medical fraternity is the ultimate. So I always want to recognize those who have sacrificed for our Indian Medical Association. And let me begin by saying, I will not take much time, but I will also not like to discuss issues here on such a important occasion, it's hats off to this branch. I have been going around in the morning, visiting all the venues of the sports. It's mind-boggling that, this branch can bring together a leadership which can sustain a national event. Even a national conference would have been easier. It's so difficult to conduct, I'm sure they are all agreeing, so difficult to conduct. Perfect. Everywhere, whatever I have seen, small little things including providing food, water, energy drinks, and the coordination in every venue, the delegation of power, so that even the awards and presents are given then and there. So a lot of mind application has gone, and that shows the mettle of the branch. I am really proud. IMA lives in its local branches. IMA doesn't live in its headquarters. Headquarters is virtual. We don't know whether it exists or doesn't exist. But IMA local branches, they have the most important duty of keeping the fraternity together. I am sure this one exercise has united you into a team without any comparison. I am so impressed with the show that you have put up, and it again strengthens Indian Medical Association. What you have done today strengthens Indian Medical Association. You have great leaders in Maharashtra, leaders who are leading the Indian Medical Association, rightly called as the encyclopedia, Dr. Shivkumar Utre. I disturbed him in the middle of the night, even to call Delhi. And when we went to meet the cabinet secretary, and the call came very immediately that you need to meet tomorrow at this time. I didn't have anybody else in my mind. I just pulled him around in the midnight out of his bed, and there he came, because I didn't have another person who can be presented to the cabinet secretary of the government. And Jayesh, if you have to define a human being, it is Jayesh. A man with immeasurable patience, ever smiling, service to the organization, meticulously correct. Meticulously correct. You may be anybody. That doesn't mean anything to him. It has to be picture perfect. And your other leaders, your President Santosh Kadam, after 2 years of grueling state secretaryship, your incoming President Santosh Kulkarni, who has helped to bring out the PCPNDT document of Indian Medical Association. Dr. Ravindra Kutte, I don't have another president who has visited all the branches. He has been there everywhere. And all this leadership that is coming up is to strengthen Indian Medical Association. The Indian Medical Association, if you look back for the past 10 years, you yourself will feel that we have come a long way. We have come a long way. Now, be it the society or the government, they respect, they have the impression that Indian Medical Association is a powerful organization. Nothing was far from truth on August 17th, on a single call of the headquarters, not only IMA members, the entire medical fraternity of the country withdrew their services uniformly. And it was evident to the government that this one organization can not only unite the doctors, but also has the tacit support of the hospitals. This is not an easy task. Today, medical profession and hospital industry are different. You have to acknowledge the medical profession has lost the leadership in health. It has been bestowed on the hospital industry. Doctors are employees. And this has had a catastrophic effect on the healthcare of the country. And the only solution for the medical profession is to unite. And you don't unite from top. You unite from nuts and bolts and from the local branches. The 1800 local branches of Indian Medical Association. You name one organization, even a political party that is present in all the districts of India, then you understand what Indian Medical Association is. It's no ordinary organization. And we have the burden of history in that we were born in the freedom fire as part of the freedom struggle. December 27, 28, christened as All India Medical Conference. This date in last 96 years, we have never changed. December 27, 28. These were the dates of the pre-independence Congress movement, freedom struggle. And we were part of that conference which determined our freedom struggle. The second address, second conference in Lahore in 1929 of Dr. B.C. Roy is still available. That address as an IMA president in the Congress Pandal. So, we have the burden of history. We have the expectations of this nation that we are nation builders. So this is a very big responsibility to carry. I congratulate you on this occasion that you have added strength to Indian Medical Association. Struggles are plenty. Challenges are plenty. But one challenge that I see, which is germane that I can present it here, is the leadership of the hospital industry outside. And what the West has lost is the clinical medicine. West doesn't have clinical medicine any longer. And for that reason, they are not the leaders or frontiers of medicine. We have clinical medicine. Our medical colleges teach clinical medicine. We have art of medicine. We don't determine with reams of paper. We have evidence-based medicine, but we have not been blown by the West to lose our clinical medicine. So these are the two things. The external challenge to the profession is the hospital industry. And the internal challenge is that we should never lose this clinical medicine, because today we are the frontier of modern medicine. Tell me one procedure that our doctors cannot do in India. And what cost? At what cost? So be proud that today we are the frontier of modern medicine. I declare. You tell me another country who can give this much care, this much attention, accessibility, affordability. We have done it. It's the modern medicine which has done it. With a lifespan of 27 in 1947, today it is 72. Who did it? It's my doctors. Where is polio? Where is smallpox? Where is cholera? And where will be tuberculosis? All these have, by the blood and sweat of my doctors. So, our only difficulty is the internal siege that we ourselves have. If the national president gives a message, it doesn't reach my last member. It doesn't reach. It never reaches. When Jallianwala Bagh happened, that Gandhi announced Satyagraha, it reached India after 1 month. The same situation is there in Indian Medical Association. That internal siege has to be broken. If it has to be broken, I need more Chhatrapati Sambhaji branches throughout India. So, I am eternally grateful for what you have done, because you have added one more brick in the wall of Indian Medical Association. So thank you. Thank you for inviting me to be with you, to enjoy your hospitality and see your president who, runs the whole show in a way that I have never seen another organizer with so much of passion. And I am sure that you have a depth of leadership. So contribute to the branch, contribute to Maharashtra state, contribute to Indian Medical Association. Thank you so much.
Thank you, Ashokan sir, for the nice words and blessing our organization. Now I invite Dr. Sharat Kumar Agarwal sir, who is the immediate National IMA past president, to give a few words. Dr. Sharat Kumar Agarwal sir.
Respected National President, the Gandhi of IMA, Dr. R.V. Ashokan sir, Vice President of IMA Headquarters, Dr. Shiv Kumar Utre, past HSG, past Vice President and very lovable leader of Maharashtra, Dr. Jayesh Lele sir, Dr. Santosh Kadam, always smiling, helping, always available for the members, dynamic secretary and a dynamic worthy president of Maharashtra state. Dr. Anil Awad, very dynamic state secretary of Maharashtra. संतोष के बाद फिर संतोष, Dr. Santosh Kulkarni, the President-elect of Maharashtra. Very dynamic President of SAMBHAJINAGAR, Dr. Ujjwala Dahipare. And I will not name her. Please pardon me, National President. I will not compare her with Indira Gandhi ji, though I am a big fan of Indira Gandhi ji also. But today's era is different, sir. And we want Ujjwala as a member of parliament and minister. So please don't tag. The Secretary, Dr. Vikas Deshmukh, President-elect, Dr. Anupam, very helping and dynamic Dean and CEO of this medical college, Dr. Suryavanshi ji, and coming President of ASI, which is again a very prestigious organization, and all the senior and dear friends. Sambhajinagar is a very small branch in respect of Maharashtra, but believe me, there are many branches in India, state branches, lesser than 1000 members. So we can say small branch, Sambhajinagar, in perspective of Maharashtra. Maharashtra has almost 55 or 60,000 members, but Sambhajinagar 1800 member is a huge membership. And the increasing membership, the credit goes for last couple of years is none other than Dr. Ravindra Kute, the past president of IMA Maharashtra. The national president rightly said that he is the one person who probably visited all the 242 or 250 branches of Maharashtra. I requested Dr. Ujjwala last year when she was the secretary of branch, seeing the capability and the enthusiasm in the branch, I wanted that this branch should organize one kind of event, national kind of event. They organized the CGP conference, but I knew the Sambhaji branch has a more capability, more potential to organize a bigger event. Somehow it could not materialize last year, and we did in Vijayawada, and I was there also in Vijayawada last year. Vijayawada is a very big branch in comparison to Sambhajinagar. But seeing since morning, the preparation, the level of the coordinator, most of the coordinator has been herself or himself are international player. That is a great achievement, because even if we want to organize in Delhi, probably we will not be having that much of this caliber, this level of the coordinators. So great potential. So see Dr. Ujjwala, it satisfy my statement and stamp my statement that you have the potential. You are the right person to organize the sports festival or a sports festival of IMA headquarters. I would like to congratulate all the participants who are participating, who have come all across country to participate here. See, in IMA, it is hardly mattered who wins, who loses. The importance is in participating. Because sports is not our career. Our career, our profession is medical. So, the IMA want to percolate this habit amongst the member to develop one or the other kind of one hobby, whether it is a singing, acting, extracurricular or sports, because it helps in easing out the stress which we occupied in day-to-day practice. So that is why IMA started these kind of event, whether it is culture or the sports, to participate. And I am very happy that almost 1000 participants are participated and 300 from the outside Maharashtra. It's a good number. I congratulate you, and I wish the entire event should be very successful. And next year when we come, or in coming year we say we met Ujjwala as a MP or MLA or some minister. That is my wish. And with these words, I again congratulate all of you for this wonderful event. And thank you for inviting me and giving me opportunity to meeting all you wonderful person. Thank you very much. Long live IMA.
Thank you so much, sir. I would now request any big event needs sponsorship. So I would now request Dr. Ujjwala to please felicitate our sponsor, Dr. Sasude, sir. Dr. Shekhar Jadhav, sir. Shekhar Jadhav, sir. Sorry, Shankar Jadhav, sir. Our corporate masters, Rabindra Singh Dhami, Praveen sir, please felicitate. Mr. Rajesh Jadhav. Mr. Rajesh Jadhav. Just like the sponsorship, we also having 13 great events, sport events going on. We have a few coordinators who are available here in the hall, and I request our president and secretary to please felicitate them. Raute sir is the chess coordinator. Dr. Akshay Maravar sir, he is the table tennis coordinator. Dr. Archana Sane, walkathon coordinator. Dr. Benazir Jadhav, basketball coordinator. Dr. Archana Sane, walkathon coordinator. Dr. Amruta Bhal Singh Jawar, athletic coordinator. As we are felicitating our coordinators, we also like to felicitate one winner who has been winning gold after gold after gold. And she is Dr. Sapna Nene. She is a plastic surgeon from Nasik who has been winning golds in swimming competitions. मैं भी लेती ना अतुल के बिहाफ पे फिर वैसा नहीं जो है वो है. Thank you so much. Now I request, please be seated, dignitaries, please be seated. Now I request our President of Maharashtra State, Dr. Santosh Kadam sir, to guide us with a few words. Thank you so much.
Good evening, friends. Honorable Chief Guest of today's sports function, SPORTSCON, Dr. R.V. Ashokan sir, a very learned, and we are always feel it is a bliss to listen to him expressing his views on various issues of IMA. I was not that much fortunate to have him in my installation, which occurred just 5 days back. Dynamic past president of IMA headquarters and one of the youngest president of national president, Dr. Sharat Kumar Agarwal, whom I say guiding star, who is with me for since my MMC tenure, and just now rightly said by Ujjwala as an encyclopedia, Dr. Shiv Kumar Utture, the most humble and techno-savvy past SSG and past president of IMA headquarters, Dr. Jayesh Lele, Dr. Praveen Suryavanshi, Dean of MGM, President-elect Dr. Santosh Kulkarni, newly elected Secretary of IMA Maharashtra State, Dr. Anil Awad, Dr. Ravindra Kute, past President of IMA, who really instilled enthusiasm in entire Maharashtra and all the branches. My friend Dr. Ingole, who is the chairman of the Cultural Committee, Dr. Vasant Kumar Lunge, who is the incoming Joint Secretary of IMA headquarters, my senior and my friend, MOH. I think this must be the only branch where MOH is regularly coming for all the IMA function. Dr. Paras Mandlecha sir. I guess I'm not forgetting anybody on the dais. And in the audience, past president of IMA Maharashtra State, Dr. Londe, who collected a huge fund for the IMA building. Dr. Gade, past president of CHHATRAPATI SAMBHAJINAGAR, the most popular man of CHHATRAPATI SAMBHAJINAGAR, Dr. Anupam Takalkar. Dr. Ranjalkar, who is the vice president with me in my team. Then in the audience we are blessed with the past president of CHHATRAPATI SAMBHAJINAGAR, Dr. Somani sir, Dr. Darak sir, Dr. Pole, Murti Lahan Kirti Bahan, international radiologist. From here, Dr. Sane sir, my senior and alumni, Dr. Manoj Saswade sir, Sangeeta madam, Roprekar madam, super sportswoman, Sapna madam, all my friends, all the sponsors, press and all, hats off to you, Ujjwala. You have a galaxy of stars on the dais. And being president, my wife always says you have to limit your speeches in the IMA functions. Here, usually the audience keep on tolerating the speeches of the IMA leaders to listen to the chief guest talk. But already you listened to our respected Dr. Ashokan sir. Good venue. It's a successful conference. I think the faith shown by the IMA National for allotting the national event, sports event to this CHHATRAPATI SAMBHAJINAGAR, which is the 5th largest branch in Maharashtra and is one of the happening branch of Maharashtra, and with very dynamic leaders all throughout their tenures. We today, actually this is the formal inauguration, छोटे खानी program म्हणता येईल, जेवढे stars, जेवढे audience आहे तेवढेच डायस वरती पण लोक आहेत. परंतु in true sense, I think we went to all the venues, 13 events, and I witnessed and cheered all the players who have come from all over India. And then we released the balloon. I think that is the real inauguration of a sport event. Along with that, you have sports conference also, and dealing on various sport related issues. With this, I think my best wishes to this branch, and this is just 5th day of mine since I took over the office. I know this is the prestigious post, but with this, lot of responsibilities come, and you have a lot of expectation from me. I started acting. I visited in last 5 days. Visited IMA state office twice, and then went to Times of India. Also, we had to do a image building for our IMA. And then there happened one assault incidents in the VN Desai hospital. We tackled it very well. We supported the students, and they successfully, their demands were accepted. The Commissioner of Mumbai, he himself came to the hospital and accepted all the demands, including the police personnel. So I think there are a lot of responsibilities on my shoulder, and I will try to restrict the inauguration and the installations. But this is also part of building of IMA. Unless and until you go and mix with the periphery and all the IMA branches, there will be no horizontal and vertical connect. So that is also, may people criticize it, but that is also part. But along with that, I think I will definitely going to deliver good for the on various issues. With this, many best wishes to this branch. Ujwala, whom just now Ashokan sir called as Indira Gandhi. Again, I'm coming to that issue. I think you have to gracefully accept, that is a really iron woman, and she tear apart Pakistan within 24 hours into two, as Pakistan and Bangladesh, and once for all, we got a peace. Our nation is enjoying that peace, So in true sense, not as a politician, but a super woman, a powerful woman, Ashokan sir, you declared as Indira Gandhi. I think your BJP party will not object it in true sense. I think with this, many best wishes to all of you, and thank you. Jai Hind, Jai IMA.
Thank you so much, sir. I now request the Dean and CEO of MGM, Dr. Praveen Suryavanshi sir, to speak a few words. Thank you, sir.
Namaskar, good evening. All respected dignitaries on the dais, our headquarter president, Dr. Ashokan, and all office bearers of IMA India, President Maharashtra, Dr. Santosh, President Aurangabad IMA, Dr. Ujwala, all office bearers of IMA, all respected senior colleagues and dear friends. On behalf of MGM Medical College and Hospital, CHHATRAPATI SAMBHAJINAGAR, I invite all of you and I welcome you all for these national sports events at CHHATRAPATI SAMBHAJINAGAR. And also I congratulate Ujwala and all our team members for hosting this event in such a great enthusiasm and great success. So big applaud to team IMA Aurangabad CHHATRAPATI SAMBHAJINAGAR. And I echo the sentiments that expressed by Dr. Ashokan that medical profession is going through a great turmoil, and we need to come together if we really want to face it very positively. So it's not only that as a medical doctors we have to come together, but all different organizations and the bodies, we must come together very strongly, very committedly, so that then only we will be able to face it. I agree with you all that, initially this medical profession was between the doctor and the patient, the service provider and the service seeker. But now there are insurance companies, there are TPAs, there are these corporates. So there are so many stakeholders who are not otherwise the part of the healthcare service providing. but they are having upper say than the people who are giving actually services. And who is blamed? The innocent people, medical service providers. These people, they have 50 to 60% stake in the all expenses of the healthcare services. And blame, who is blamed? कि doctor लुटता है. No one is looking at all these other stakeholders who are not giving services and taking major chunk of the healthcare service cost. So we have to come together, otherwise we'll be vanish as a healthcare service provider. So we must come together very strongly, and I commit myself as a President-elect of ASI that we will be with you for every step of your fight. Thank you so much. I wish every success for these 2 days conferences, and I should IMA Aurangabad will be more than happy for any future venture for the whether it's a medical or sports, will be happy to participate. Thank you so much.
Thank you so much, sir. I request Dr. Utture sir to say a few words.
Good evening. Respected National President Dr. Ashokan sir, first of all, thank you for those magnanimous words that you have said about me, but let me tell you the secret of this man. You know, just like how Eklavya learned just watching his guru, we have been watching you as a guru, sir, for the last 1 decade. So whatever we have learned in IMA has been because of you. And to tell you the dedication of this person, he landed yesterday at Mumbai airport at around 1:30 in the night. And again at 3:30 he was on the airport to come to SAMBHAJINAGAR. So, and whole day he has been roaming about with us in the sun and has visited almost all the 13 sites of the sports. So thank you very much, because you have come to Maharashtra and we are very much thankful to you for that. My very close friend, brother, Dr. Sharatji, a multifaceted person, and let me tell you, he's a fantastic administrator, and his education has been in administration, but then you have to see him singing to know that the singing world has lost a gem and we have gained in the medical world. So he is also a multifaceted person. My friend Dr. Jayesh, with whom we have fought a lot of battles in Maharashtra. One thing that everybody was saying, you know, that calm, quiet, very patient. I think we should try to get the certificate from Baba Ramdev. Then we will agree to that, Jayesh. Very meticulous person. My colleague who stood like a rock behind me when I was in MMC, Dr. Santosh Kadam, and I have seen him grow from strength to strength, from that shy boy, young boy who entered with us in MMC almost around 14 years, 15 years back. And today I think he deserves this accolade and this seat as the President of Maharashtra State. And then of course, whenever you have a dynamic person, there should be someone opposite to cool him down. And that coolness will be given by, I know, by my friend Dr. Anil Awad, also with whom I have been working for a very, very long time, the Secretary of Maharashtra State. Then we have Santosh this year and we have Santosh next year also. So there's going to be Santosh in IMA Maharashtra State. So he is there so to continue the legacy of Santosh over there. My friend, my colleague, and from the same faculty, Dr. Suryavanshi sir. We are both surgeons, and he has also, just like I have grown in IMA. At one time I was in ASI. I left ASI and got into this IMA organization, but he has also now become the president of, and he'll be taking over now. So all the best to you, sir, for your whole tenure the next year, because I know how bad surgeons can be when they are sitting in a meeting. Then Dr. Santosh Ranjalkar, Vice President, sir, very, very senior person. I have been seeing you for ages over here. Then Dr. Lunge, sir, who is now the national figure over here, and he's going to be there for the next 2 years, and that definitely is going to help IMA Maharashtra State because he'll be a voice in the headquarters in the next 2 years. Then I come to my colleagues here in Chhatrapati Sambhajinagar. I think after Delhi, this must be the only branch which I have visited the highest number of times in the last 1 year. So almost I can't count, 5 or 6 times I have been over here, and it feels like home when you come over here to Sambhajinagar. Dr. Ujwala madam, I have known her right from when she was doing plastic surgery in Mumbai. Right from those days, I have known her, but today she's become like a full-blown lotus over here. They call her Indira, they call her Iron Lady. But I have seen her working. I have seen her enthusiasm in the morning whenever we visited all the sites. And she had everything in her hand ready. You know, that is a leader. There were people who were working for her at every site. But it is a leader ultimately to whom they look upon to tell them exactly what they do. And that is the quality of a leadership that she has. So congratulations to you, madam. Of course, Vikas, as I always tell him, that most probably Sambhajinagar took up this because of Vikas, because he is a sportsman himself. So congratulations, my friend Dr. Gade sir, also who has been with us for very, very long. Takalkar also, who's been there with us for a very long, long time. So, and of course Kailash, where is he? Kailash, the most enthusiastic person. I've never seen him sitting on one seat for a long time. Apt man for being the brand ambassador over here. So today, I'll tell you, I have visited almost all the 13 places, what I have seen today. And let me tell you, Ujwala, you and your team have today put Chhatrapati Sambhajinagar on the national map of IMA. Because you have done something. There were around 300 people who have come from out of Maharashtra over here. We met people from Tamil Nadu, from Kerala. And I saw Dr. Asokan very happy because he could speak to both of them in the native tongue. And then from Haryana, Telangana, Karnataka, everybody. And so, see, what happens is when you collect all these leaders, these doctors who come are the leaders from there. So the name of Sambhajinagar goes to all these states. And that's why I'm telling you today, you have put the flag of Chhatrapati Sambhajinagar on the national flag. So keep it up. You have to do a lot of work. It's not that, work stops over here. Potential is there in this branch to do a lot. I won't take long because already I think we are delayed. But and I've already spoken 5 times in this branch. So there is enough I have spoken also. So all the best, and the teamwork which I saw, the enthusiasm. Everywhere where we went, there was an international person of repute of that, particular field. But he was working like a common man over there. And that is the greatness of, the teamwork that you all have got over here and the team that you have created over here. So keep up this team. A lot of potential is there, and we are sure that Chhatrapati Sambhajinagar will go on, the name will go on all over India in the near future also. Thank you very much for inviting me.
Thank you so much, sir. Gratitude needs to be expressed whether it is a small conference or a small event. So this is a national event. So now I request our secretary for the vote of thanks.
Good evening all. Thank you is such a prayer that cannot be seen or touched. It must be felt by heart. I feel really honored and privileged to get this opportunity to propose a vote of thanks on this auspicious occasion of inauguration of IMA National Sports and Sport Conference 2024 at Chhatrapati Sambhajinagar, Marathwada, Maharashtra. I would like to thank all the honorable dignitaries on the dais and off the dais who have blessed us with their radiant presence. As an organizing secretary of this IMA Doctors Olympics, I would like to thank all the sports medicos and conference delegates who have come from different states of India for their sportsmanship and cooperation on and off the playgrounds. My sincere thanks to to the present and past respected members of IMA, office bearers, managing committee members, members of different wings and committees of IMA CSN, and at the same time all the sports and non-sports committees for their extraordinary work to make this event a big success. I want to thank all the sponsors, the donors, and the special thank to MGM Institute for its generosity and offering help in all possible manner. Thank you, Dr. Praveen, CEO of MGM Institute, for standing with IMA CSN through thick and thin. IMA is really in debt of your help, sir. Let me quote Nancy. You have to have a real love for the sports to carry you through all the bad times. So we here, we have played with heart and we have won with soul. Thank you, all of you again, and I think there are 2 more days. Please be with us for the 2 more days, all the sport medicos, and thank you all. Thank you very much. There's the national anthem. Please stand up.
We'll start together.
मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्रविड़ उत्कल वंग विंध्य हिमाचल यमुना गंगा उछल जलधि तरंग तव शुभ नामे जागे तव शुभ आशीष मागे गाये तव जय गाथा जन गण मंगल दायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे भारत माता की
High tea is served outside the hall, and I invite for the cultural night, our members are going to perform at Rukmini Hall, followed by delicious dinner. I invite you all.